Okay, we're going to go ahead and get started. Good morning. This is a great crowd. Welcome. We appreciate you all taking the time out of your schedules to be here. I'm State Representative Stephanie Stuckey-Benfield. I'm one of the chairs of the Direct Entry Midwifery Study Committee. The other co-chairs, Representative Mabel Thomas. She stepped out just for a minute. She will be back. I know Nazra is on her way, and we have Debbie Pulley, who's on the committee, and Dr. John Schilling will be here, but he's running late. But we need to get started because we have a very tight agenda today. I will apologize in advance. I'm going to have to leave early. It's my son's Christmas party at school, so I have to be there. So if I sneak out, that's why, and I apologize in advance. We're going to go ahead and get started. Just a real quick technical note. Anyone who's speaking, you'll just see at the top of the microphone, just click it on, and then when you're done, click it off. Otherwise, it causes feedback. We are being televised. There's a camera over there. So if you look over there, you can smile on the camera. We are on the web, so folks can, I always wonder if anyone's out there watching us, but it's possible to get on the web and watch these proceedings. So great. And Sally Fox, our research assistant, wave your hand, and Terry Long with the Legislative Counsel's Office are the support staff, and we really appreciate all the hard work they've done. So we are now going to get started. Our first speaker today, and I know he has a tight schedule, and we appreciate him being here, is Mark Trail with the Department of Community Health. He is Director of Medicaid. I think the official title is Chief of the Division of Medical Assistance. Got that right. And he's going to talk to us about Medicaid coverage for midwifery. So thank you very much for being here. You're welcome to take a seat.
This is on. There we go. All right. Okay. All right. Thank you, Madam Chair. Excuse me, members of the board. Please forgive me if I have to clear my throat once in a while. I did spend the weekend with my grandchildren, and whatever they had, they gave to me. So it is my pleasure to be with you today and present some information to the committee with regards to coverage of midwife services in the state of Georgia, in particular in the Medicaid program. First of all, I would say that actually I'd hope to be able to tell you how long we have covered midwife services here in this state. It was before my time. I've been with the department since 1998. And so I think it was the early 90s, but I'm not absolutely certain about that. Most recent information I have, thank you. Most recent information I have, we hope to have the information for FY06 very soon, but for FY05, there were actually 22,755 unique moms served through the Georgia Medicaid midwife program. We paid $13.6 million for midwife services in FY05, and there was 213 enrolled providers that filed claims during fiscal year 05. I doubt that the numbers for 06 would change much, but obviously they can fluctuate up or down some. Currently, in Georgia Medicaid, excuse me, by the way, for everyone's information, all of our policy manuals can be found on the web. It's the 3Ws.ghp.georgia spelled out .gov, and you go to the provider section and then a provider manual section on the web, and you can find the nurse midwife provider manual down in the as you scroll down on the menu of some 65 policy manuals we have there. Currently, we cover, our program is actually entitled Nurse Midwife, and as the title would infer, we cover nurses who then have some additional certification in midwifery, and there are some specific requirements in that regard. I'll go over those now. First of all, the nurse must be a certified, or a licensed nurse, I'm sorry, licensed nurse here in this state. It does not have to be a nurse practitioner. I know there's some that believe that were the case, but that is not the case. They can be a licensed RN as well. But then they also have to have certain additional requirements. Specifically here in Georgia, we require that they also be certified by the American College of Nurse Midwives, ACNW, and in their enrollment process they have to provide to us a copy of that certification. They have to remain in good standing, of course, with that group, as well as they have to maintain their license as a registered nurse in this state. I thought it might be of value to share a little bit with the committee about some of the federal requirements as they relate to the Medicaid program. There's actually federal requirements both in Medicare and Medicaid, interestingly. We wondered exactly under what circumstances folks on Medicare might need a midwife, but you never know. Disability, thank you. I knew that. It was a bad joke, but I tried. Okay. All right. Being serious, there are some federal regulations specifically as it relate to the Medicaid program in CFR, if I could quote a bureaucratic number, CFR 440.165 address the specific requirements as it relates to, again, Medicaid and coverage of the midwife services. First of all, it does stipulate that the services be provided in an inpatient or outpatient hospital setting. It further stipulates that they could be provided in a clinic setting. It would be, I suppose, important for the committee to know that there is no allowance that we find in the federal regulations for those services to be provided in the home. In addition, I already mentioned Georgia's requirement that the nurse be indeed a registered professional nurse, RN, in this state, and have a current license. That is a stipulation that comes directly from the federal regulation. In addition, they have to meet whatever state scope of practice requirements there may be in the scope of practice laws in whatever state they're practicing in. Here in Georgia, it does require the additional certification to be a midwife. The federal regulations do allow a little more flexibility in terms of the certification, and without reading them verbatim, I'll offer some of the highlights from them. Of course, one of the first is that they could be currently certified as a nurse midwife with the American College of Nurse Midwives, as I mentioned already is our policy. But there's some additional allowance. Or they could have satisfactorily completed the formal education that upon completion qualifies the nurse to take the certified examination from the ACNW. So in other words, they could have completed the coursework but not yet taken the test. The federal regs do allow Medicaid coverage in that circumstance. And the third "or" is has successfully completed a formal education program preparing a registered nurse to furnish gynecological and obstetrical care to women during pregnancy, delivery, and the postpartum period, and care to normal newborns as practicing as a midwife for a total of 12 months during any 18-month period prior to August 76 through July of 82. So in essence, that last exception, or the last "or", is sort of a grandfathering allowance for folks that may have been practicing and completed education prior to those dates that I mentioned. Let me read the whole sentence, if I might. And was practicing as a midwife for a total of 12 months during any 18-month period from August 1976 to July of 1982. And there are some specific dates in there, but that's the general month. I'd be happy to entertain any questions the committee may have.
Question about the federal regs, because there was a lot of information. I was trying to take notes. Do you have a copy
I'd
of
be happy
that?
To leave this with
that
you,
would
certainly.
be helpful. The federal regs require that the midwife be a registered nurse. Is that what I heard you state? So how do states that do provide Medicaid coverage, but they have to keep within some federal requirements, even though it's a state-run program, correct? Mm-hmm. How do the states that do provide Medicaid coverage for the certified professional midwives, the CPMs who don't have the nursing degree, how do they provide that if the federal regs are saying they have to be registered nurses?
It's possible there are some states that will run through their Medicaid programs state fund only types of services. However, I'm not personally aware of specific states that do provide the coverage to other than those that have an RN, but I would be happy if there are some of those states. I know most of the state Medicaid directors, and be happy to have that conversation with them to affirm whether that's in fact true or not. Sure.
I would appreciate that, because that's something we're interested in this committee.
The federal government is the one that's given us the mandate that only nurses can be paid.
That is correct. That's what we have in the Code of Federal Regulations.
Okay, and then the question she asked may would give us an opening so that we may do it from the state level. And then the other thing is dynamics is that then those who are listening, because these persons who are here today are throughout the state of Georgia, then they can possibly call their congresspersons and begin to sort of talk with their congressperson about opening up that situation where more than just nurses could be paid. So do y'all hear the mandate I just gave to the people who are in the room? If it's federal, we go to the next level. In fact, that y'all are throughout the state of Georgia is better. So that means you can call Representative John Barrow, you can call Chambliss, you can call Representative John Lewis, but we do need to make some calls anyway around this, because I do think it should be a situation where it could be a little bit more open. So that's a thought as an action item that might be done by those who are interested. Are y'all with me? Shake your head if you're with me. All right, thank you.
If I might add,
Sure.
Madam Chair, that I think it is important for us, because we do like to make sure folks understand that when we come and make testimony such as this, we are strictly talking about what Medicaid covers and not about scope of practice and any changes that the state may opt to pursue there.
If Georgia were to expand the Medicaid coverage to include CPMs who do out-of-hospital births, would that change be initiated through a statutory change, or would it be a regulatory change at the administrative level?
If I could ask for clarification, are you talking about for Medicaid coverage or change in scope of practice?
Medicaid coverage.
I believe that we would have to go to the feds to have a conversation about whether federal participation is available to cover the service. Then I also think there would have to be some pretty serious conversation about whether Medicaid wanted to get into the business of covering services, healthcare services, with only state funds. It's my understanding that there is a state statute that stipulates that we can only pay for services that have federal financial participation available to them, and there are some rather complex other legal arguments to be concerned about if we were to decide to cross that bridge and start covering things that didn't have federal participation.
So I'm assuming the states that do allow it don't have such a statutory restriction on their books.
I would assume so, but again, I'd be happy to do some research if someone get me the names of a couple of states. I'd be happy to check that.
We can get you a list of the states.
Okay. Great.
Okay.
Okay.
I do want to announce we've been joined by Dr. John Schilling and Ms. Nasra Anor. I apologize for that. Ms. Nasra Anor, who are both committee members. Do any of the other committee members have questions?
Sure.
Thank you very much. We appreciate you being here.
My pleasure.
Okay, our next speaker is Dr. Pam Gallop. She is an obstetrician, an OBGYN from Savannah, and she's also president of the Georgia OBGYN Society, and she has a PowerPoint presentation for us. So if you need a few minutes to set up, that's fine.
Oh, I know. Okay, want to start by saying I've been warned that this is going to be real tough for me. And I want to start by saying I'm not here in an animosity kind of level. And these children are so beautiful, and I assume they've all been born by home deliveries, and I think that's great. And I can tell you that from my perspective, the kids don't help. I mean, they're great, and they make a big point as much as you. Last year, this man, I'm sorry I don't know your name, stood up, and I was very, I had heard about this committee meeting, the study committee last year, and I came up here, and I absolutely was flabbergasted, don't get upset, at the absurdity that we were having this conversation. And I know I came across like that, and I apologize, because I'm coming at it from a different perspective, and what I'm trying to do today is explain to you that perspective, okay? But you made an incredible, without any children there, impact on me. It was just a very beautiful statement, and why I went into OB, because you fall in love with the babies, okay? And it's a very family-oriented specialty. Dr. Schilling can tell you that we have the only specialty that our patients don't die, and and your personality gets pulled to that, okay? And most of us have similar personalities, and as you get older, you realize that people go into different things because of their personalities. So lab radiologists shouldn't talk to people at all, and some surgeons shouldn't talk to people at all, and it's good that their patients are mostly asleep, and we tend to talk a lot. That's probably why you're sitting in waiting rooms for long periods of time, because we're looking at pictures of babies, and now that they're 10 and that kind of thing. So I don't want this to be an animosity, but kind of thing. But I want to tell you where we're coming from, and just our perspective, since I'm kind of representing this whole state in putting what we feel forward.
I do want to say welcome. We are very glad you're here.
Thank you.
And I love my OBGYN, by the way. Dr. Deborah Brain and Dr. Kevin Gomez was my neonatologist, so I don't think we are anti-doctor by any means.
It's not the whole screen. I wonder what... Well, I can do it, man, with that.
You got any thoughts on how it's a setting on the computer? Yeah, it's probably the setup on the projector with the size of the screen.
Well, that's okay. I can just talk from there. I guess the... oh, there we go. So, you can't hear me? Is that better? Okay. Why is your obstetrician go, oh my God, what are they thinking? Okay? Because this is what we are ingrained in our heads from the time we walk in. Okay? And that was my big point last year, was this study has been done. Okay? We know what happens with home deliveries, because in the early part of this century, or the 20th century, maternal death from pregnancy was the #1 cause of death in women. Between the ages of 20 and 50, the #1 cause of death in women was delivery. Okay? When people started delivering in hospitals, the maternal death rate plummeted, as did the neonatal death rate or perinatal death rate. 1900, 1 in 100 deaths per live birth. By 1991, in 10,000, 99% decline. That's it in a nutshell right there. But there are caveats here, and I understand that. And again, I looked into it mainly because this man stood up and was just so passionate about what he was talking about. Now, why have there been improvements in care in the hospital? Number one, infection. We got penicillin and now other antibiotics, and one of the biggest causes of maternal death is infection after delivery. Puerperal fever is what they called it. We call it endometritis, chorioamnionitis, and we treat it with antibiotics, and it has significantly decreased the death rate. Use of cesarean section when there's a problem, especially placenta previa, and where the baby just cannot come out. Fluid management when there's severe loss of blood, blood transfusion, and prenatal care. Now, why do women choose home birth? Desire for low intervention birth. I'm going to tell you here that I am an obstetrician, but I'm also the mother of twins, okay? And I'm telling this on understand a webcast to the world, is that I also had a breech extraction. And I said to my two partners who took me into the delivery room to deliver me, don't you dare section me. Now, wasn't that something to put on my partner's head? Don't you dare section me, okay? Now, that's a lot to put on them. But I wanted to deliver vaginally at all costs with twins, okay? So I'm there with you. I understand where you're coming from and how you want control. Religious or cultural concerns. There's a lot of people don't want to go to a men, especially in the Muslim population. Concern for iatrogenic complications. What that means is we caused a problem. We gave you a bad bacteria, or we did something wrong and gave you the wrong medication. Somebody had some bad outcome, or the baby was fine and some nurse did something, or some tech did something in the nursery, and the baby was hurt. I mean, yes, things like those happen in hospitals. Fear of hospital care, desire for a familiar environment, your own bed, your family being present, which was his big point, how beautiful it was to have the whole family there. Lack of finances for the hospital. Okay, I can tell you one thing about the finances also. I heard from the previous committees here that somebody said they're getting $2,400 to $2,600 a delivery. My first response was, are you hiring? Because we don't get that. Okay? And lack of transportation. But I understand the hospital bill is significant, and that is the biggest part of the cost. There's no question that health care providers have not been considerate to the pregnant women. Absolutely no question, and I'll give you that. We treat you as you're seriously ill, and there's nothing wrong with you except that you're pregnant. You're forced to conform down a pathway of care that we want you to go. We want you to go in the bed. We want you to put you on the monitor. We want to put an IV on you. We don't want you to move. We want to be able to watch the monitor and go to a different room. It's a very sterile environment. It smells of sterile chemicals. We leave you. 7 o'clock comes, it's shift change, the whole place. People die at shift change. That's what the doctors always say. People die at shift change. All the nurses disappear. They all go into a room. They talk about each other, and you can't get anything done. No matter what you do, you can't get anything done at shift change. And then we come back in, everybody introduces themselves again. They have no idea who you are. And we say, hey, we're going to take care of your baby, and we're going to deliver your baby. It's not nice. Epidurals are encouraged. I encourage people to have epidurals, and I don't think it's from a, it's very hard to sit there and watch your patient hurt. It's not that I want you to do something, and I assume other obstetricians feel the same way. I really don't want you to hurt, and I can help you so you don't. It's not that I want to take your control away. You feel bad, and part of what we do and why we went into this is to help people, and watching somebody really hurt when you know you can fix it is difficult. Emphasis is on the fetal monitor and not the mother, and the family may be excluded. Some places only allow certain family members or a certain number of family members. When I was, it was probably in 1990, just when I was getting out of my residency, huge changes were made. There was birthing rooms replaced delivery rooms. Women stayed in there. You labor, you deliver, you recover, and you leave from that room, stay in the room the whole time. They're much nicer. They got birthing rooms with hardwood floors and champagne and steak dinners at night if you want. And some places even have suites or something that the family can stay in with nicer beds, not just pull-out beds for the father. What did hospitalization do, however, when we pulled people back into the hospital? You can see here, well, it's not that as big as I want. 1935 maternal mortality rate, 12,000 women died. It's very hard to get numbers here, but you can see the trend. The goal for the CDC is to get down for a neonatal mortality rate is 4.1 per thousand babies born. That's the goal. And you can see in 1950 it was up as high as 20.5. So we see the positive things that happened with hospitalization.
Can I ask before you leave that slide, what is do you know what the rate is in Europe? Is that about on par for?
I don't know what the rate in Europe is.
Just interesting. Can we get copies of that, of the PowerPoint presentation?
Yeah.
Okay. It would save me copying all this.
Maternal mortality, neonatal mortality, I mean, let's be very honest. It affects the people who are most socially and economically deprived. I have it later here that there's, the last statistics I saw was there's a 4-to-1 black to white mortality rate. Okay? And that's a huge problem. That's a huge problem. It's a non-Hispanic black patient. It's 4 times the rate, and the babies have 4 times the rate of mortality than. These deaths occur from sheer lack of adequate facilities, lack of antepartum care, lack of blood, and management errors. If maternal and perinatal mortality rates are to be brought to the minimum, which is what we want as none, these deficiencies in maternity and obstetric care have to be corrected. So you see where I'm coming from. We're trying to get a maternal mortality rate to 0 and a neonatal mortality rate to 0. But we got to get our whole goal has been get these women in. We got to get them in. We got to get them prenatal care. You hear it everywhere. The March of Dimes, all these organizations that are trying to get prenatal care, get them in. If we can just get them in, we don't have these people coming with no prenatal care and these disasters. What have we always been told? How do you do this? How can you lower this? The things that have worked in the past: better trained personnel, better equipped facilities, emergency measures readily available. The objective of obstetrics is that every single pregnancy culminate in a healthy mother and a healthy baby. We have babies die. They do. It happens. They're for congenital anomalies. They come in with a stillborn. Things happen, and you can ask any obstetrician that we've all dealt with perinatal death. You remember every patient you remember. But what's the hardest for us is a maternal death. Okay, right? And it's not that the baby wasn't as important. There is nothing like a maternal death. Nothing. For the family and for your healthcare providers, nothing is worse than a maternal death. Nothing. For the people in the hospital, nothing is worse than a maternal death. The information goes through rapidly everywhere. There's nothing worse than maternal death. The thought of somebody being out there and bleeding to death or having a hypertensive crisis, once you see an obstetrical hemorrhage, it's profound. You cannot put it in words. The last true obstetrical hemorrhage I had was 46 units of blood in 2 days. It is the most frightening event that you will ever see. Now, does that happen that often? No. Obstetricians strive to minimize the number of women and infants who die as a result of the reproductive process or are left physically injured therefrom. This is what we do. And it just happens that what we're trying to do and how we're always taught and told to do it doesn't go along with actually what you're wanting to do. And we just have to agree that that's where this diversity is coming from. But it's not because we don't want, you think this is terrible and you shouldn't deliver it at home with your family. It's coming at it from a different angle, and you have to understand where we're coming from too. Because I'm very much more understanding of where you're coming from and why you want to be at home. Hypertension, embolism, a blood clot in your legs or somewhere that travels to your head, hemorrhage, an infection or lesion causing maternal death in women delivered after mid-pregnancies. None of these can be handled at home. Not one of them. No.
Slow down on that one for a second. Let me see what you're saying.
While we have this pause, let me just say one thing. Those people who will desire a seat, if there is a seat by you, raise your hand. If not, then pull these chairs here or whatever. Any way you can put a chair, put it. It's fine with us. If you can get these chairs and put some of the guys, y'all can put some back in the back. Then what we need to do, we want to accommodate you as best as we can. So if there's any chairs next to you. Is that a chair? Is that a space?
Once she finishes the PowerPoint,
What about that? What up here?
Okay, next thing I want to talk about is ACOG. Now, I understand ACOG took some hits at the last couple meetings. I wasn't here, but I understand they took some hits, and, you know, it's kind of construed as a bad organization.
What is ACOG?
ACOG is the American College of Obstetricians and Gynecologists, okay? They assure quality of care by assuring that providers of care meet educational and professional standards of a certification process. They recognize the educational professional standards currently used by the American Midwifery Certification Board to evaluate and certify midwives. It does not support the provision of care by lay midwives or other midwives who are not certified by this board. The American Midwifery Certification Board, formerly known as the Certification Council, incorporated in 1991, develops and administers a national certification exam for certified nurse midwives and certified midwives. As the gentleman from Medicaid said, certified nurse midwives are registered nurses, graduated from a midwifery education program accredited by the American College of Nurse Midwives Division of Accreditation, have passed a national certification exam administered by the board. Certified midwives are not nurses but graduated from a midwifery education program accredited by the American College of Nurse Midwives Division of Accreditation and have successfully completed the same requirements, have passed the same board as certified nurse midwives and adhere to the same professional standards. Certified professional midwives certified by the North American Registry of Midwives. I have found some places they have to pass written exams and have some, although some, it seems some don't, hands-on experience, and the legal status varies. So we have, and I may be wrong here, and I'm going to explain why I might be wrong, okay? I understand. There are so many names for what you all do. There's not a real standard here. The lay midwives, direct entry midwives, independent midwives, granny midwives, and certified professional midwives are also lumped in there somewhere. There's not a list, and this is what it is. And that needs to be standardized with the standardized education thing, so everybody's on the same page. I looked all weekend, and I found so many different names and education requirements, and it is extremely confusing. Okay? The definition, the education, and certification, and it's misleading. I mean, the certified professional midwives really sounds as good or better than a certified nurse midwife, just with the professional in there. It's just misleading and confusing. This can lead to your advantage or not. It doesn't lead to the advantage of the certified nurse midwives because they're all lumped in and they've done the most work. Georgia is 43rd in the nation for perinatal and maternal mortality. We've been 49. We were 49 for a long time. We keep trading places with Mississippi and other places, and we're very happy when we keep moving up. We're in the right direction. This is one of the things we're worried about too. Are we going to go backwards if this all happens? That's kind of in the wrong place. There's racial differences in perinatal and maternal mortality. Certifying lay midwives to be equal to certified midwives. Is that what we're going to do here? Are we making everybody equal? My one question to the certified nurse midwives is, you've done all this training, a master's level education, and passed the boards and did everything you're supposed to do and is recognized, but we're trying to equalize everybody with people who have had no formal education and have just done an apprenticeship. I don't understand that, and I would really like some clarification there. Is that what we're doing? Are we equalizing all midwives to practice in this state so that certified nurse midwives, certified midwives, certified professional midwives, lay midwives, and the other names, deck entry, independent, everybody's going to be equal? I have a question for the certified nurse midwives. Why is that okay for you? I'm not saying this in an antagonistic or I'm baffled by why you go through all this training, but you're willing to say, I'm just this person who's just done an apprenticeship and 24 deliveries or whatever your apprenticeship is, that it's equal. I don't understand that. I'm baffled by it, and I think that's probably one of the big things last year when I was so, how are we having this conversation, was we have certified nurse midwives. They're recognized. They work with us all the time. I made a big point. We have the only freestanding birthing center in the Savannah area. It's a little far away from the hospital, but there's doctors that are over it and supervise, and they send us their transfers. And so, it's easy to see that it's bothersome for us because I never see the 25 people a day they deliver. I just see the couple of months that they send, that I'm working all night on. But we have this already. We have the certified nurse midwife. It looks like we're trying to equalize everybody with people with no formal education, don't have to pass boards and just have to go through this apprenticeship. Why is that okay? It's a question. I'm not being antagonistic. We have certain standards we have to abide by too. We have to live within 30 minutes of the hospital. We have to be able to do a C-section in 30 minutes. If we do a vaginal birth after cesarean, we have to be physically in the hospital. These are standards we have to do. I mean, if we're going to equalize everybody and say, okay, you can go out there and deliver babies, should they have the same standards that of just, this is incredibly basic. You have to be 30 minutes from a hospital. You have to be able to have a C-section done in 30 minutes and have some VBAC guidelines. I don't think there's any obstetrician out there who feels that now, with the legal atmosphere, that a VBAC is okay to not do in a hospital. Most hospitals now who don't have an anesthesiologist in-house won't even allow you to VBAC. The patient has no option. They either transfer them to a hospital that has this available, but they cannot VBAC. They have to have a C-section. So, I'm not against midwives at all. Okay? What is acceptable to have a delivery at home? We have to have standards here. If we're going to say this is okay, we got to have informed consent. I think the patient needs to know that if something bad goes wrong, like an obstetrical hemorrhage, a hypertensive crisis, fluid abnormalities, that she is not in a place that it can be taken care of. I think she needs to know that, and that's okay. This goes, it's back to the same thing I said last year as well, and I got very, you don't have to wear your seatbelt. You know, we're adults here. If you choose to do that, that's okay. It's okay, it's your choice. As long as you understand that those things happen, those 5 things happen, and you're putting yourself in a position that you can't get there. That's okay, as long as a mother understands that. She should have no serious medical conditions. There should be no serious obstetrical conditions, and no contraindication to vaginal birth. These are some of the things that are on standard boards and stuff that, you need to know. Hospital transfer, optimum outcome when hospital providers communicate respectfully with the home birth providers. I mean, that is a key issue here. And this is coming down to the nitty-gritty of what we're talking about, where this animosity is coming in, and besides the fact that we are taught that you've got to be in a hospital because we can give you the best care. I don't know that that's right. I'm agreeing that may not be, there are other options. I understand that. There's got to be communication between the home birth providers. The home birth providers should not be treated in a punitive manner. There needs to be exchange of records, prenatal and intrapartum information. Transfer should be done at the first sign of trouble, not this, I don't think that, I think I can handle this, I think I can handle this. At the first time you say, I think I can handle this, you should transfer. And a physician is called en route so that we're prepared. We're not just home and you're on call and that you get called for this because somebody comes in the hospital. Now, everybody's been touting these British Medical Journal results. 12.1% of patients were transferred, 83.4% prior to delivery. There were no maternal deaths. There were 7 neonatal deaths. They only accounted for 5. 3 were from congenital anomalies, 2 within 28 days of birth, and I can't find out about the other 2. The 5 intrapartum deaths, there was a cord prolapse, 2 breach, intracranial hemorrhage, and a true knot with 6 nuchal cords. Those 5 patients are only 5 out of the 5,400 and something. It's just, we can argue all day about, if you had a cord prolapse in labor and delivery. I haven't seen a cord prolapse die in 19 years I've been doing this. I haven't. It happens. I know it happens. You read about it happening. I haven't seen it. And I've had lots of cord prolapses. 2 breaches died. Those 2 babies have been saved had they been in a hospital. Intracranial hemorrhage, we never know. I mean, that can just happen. So, and a true knot with 6 nuchal cords. That's the grace of God. I've never seen that, and I don't know. But
what was that last one? I'm sorry.
It's true knot with 6 cords around the neck.
Okay.
I don't know. It's you don't know those in advance, and bad things happen, and they're going to happen outside of a hospital. If you're not in the hospital, could you have saved these 5 children? Maybe the 3. Is it worth it for that? I don't know. Bad things happen in the hospital too. The neonatal death rate was 2.6 per 1,000. It's very hard to match when you look at a statistical analysis of this journal. It's hard to match planned home birth patients to planned hospital patients because they select themselves. Okay, they're selecting themselves, so you can't really match them and get like all of you and say, okay, you go in a hospital and you go at home because you don't want to do it. So they're doing themselves. It's not a bad article. You can read it in different ways. The obstetrician's going to read it one way, and the home birth provider's going to read it another way. Now, there are some controversial legislative mandates, laws that have come up all the time. Vaccinations. You know how much people argue that you shouldn't have to vaccinate your kids if you don't want to? It's a law. I guess it's a law. It's not law. It's a mandate, right? We want you to, we push you to. It's these things that we feel like we've had to legislate for people to protect themselves. Metabolic screening of children. There's a lot of people who disagree with the metabolic screen, and they just increased it from 10 to 20, 18 or something metabolic screens. Tobacco age limits. Why do we make it illegal to smoke before you're, I don't even know what it is, 18, 21? These things are seatbelts. We pass a law so you have to wear a seatbelt. Same thing. You're protecting people from themselves. Age of marriage, age you have to stay in school. All that is just so people get some basic educations. And why do we have to legislate those kind of things? I don't know. We feel we do. And this is kind of part of it. So let's get down to the nitty-gritty. What is the problem that obstetricians have with this? Let's look at the abortion issue. I'm very pro-life. I don't agree with abortion. I don't do abortions, okay? But we all know that when people were doing them themselves, lots and lots and lots of women died. And obstetricians feel, whether you're pro-life or not, you can't go back to making it illegal because, and this is just from, I think, obstetricians' point of view. I think I can speak pretty good for most obstetricians. We don't want to get into the abortion issue. I'm saying, if you make it illegal, women are going to die because women are going to do it themselves. They're going to find somebody to do it, and they're going to do it themselves. From a purely altruistic point of view, where we're trying, our goal is to protect women, we don't want that to happen, whether you're pro-life or not, because women are going to die. That's part of it. It's almost the same thing. We see this going back to the beginning of the 19th century, where women, the number one cause of death was deliveries. Home births, will maternal mortality and neonatal mortality rates increase? I don't know. It's scary to think about it from an obstetrician standpoint. Obviously, people have done well in this room. Who is responsible for the pregnant women in trouble? And why would you let those with no formal education and not have to pass a standard board? And how can you let them deliver your children? And I understand that the apprenticeship and people are very trained and skilled at delivering babies. We have certified nurse midwives that have gone through this education. They got master's degree. They can do this. The ACOG works with them. They have a statement of working with them. I have a nurse midwife I work with. It works very well. I have no problem with people delivering at home. I would rather you deliver in a hospital because of my education and what I've learned and what I see on a daily basis, and I see the problems, and I see babies going to the intensive care unit, and it scares me to think about people delivering at home. But I don't see it. I mean, if you want to deliver at home, I mean, from just a personal standpoint, if you want to deliver at home, deliver at home. Just do it with somebody who has some standards, who's at least a nurse or has gone through this midwifery training and has passed their boards and is part of this certification board. We have this in place for protection. And then let's get down to the big thing. Now, it would be nice in a perfect world if the patients who are transferred called the doctor, there was exchange of information, nobody felt antagonistic, you don't have to call it a failed home birth, just home delivery. It's a home delivery transfer without a negative connotation. This is not a perfect world. And these patients come to the emergency room with, the 5 worst things that happen. They're either septic, they're hemorrhaging, baby's in trouble, and then it's ours. And we're responsible, and we're the ones that get sued. Okay? Your all comes down to liability. What was the biggest thing we talked about here last year? Okay? The whole purpose of all of our trips and, God, the money that was spent to get this tort reform. And here we have somebody that you're completely not responsible, somebody they've gone to somebody else, and there's no responsibility of the person who took care of them this whole time. You're throwing this liability, and there maybe goes somebody who is not a certified nurse midwife, or a certified midwife, or a certified professional midwife, and maybe they don't even know their qualifications, and they're not going to tell you who was taking care of them, and it doesn't matter because she's mine now. And I have this obstetrical hemorrhage or something, and maybe the baby dies, and what's going to happen? I'm going to get sued. I'm going to get sued because that's what people do when their babies die. Okay? And if the mother dies, you can be sure you're going to get sued. That's an automatic suit. I mean, despite how bad the obstetrician feels or the hospital staff feel or the whole hospital feels, when, oh my gosh, there's a maternal death. It doesn't matter that we all felt terrible. You're going to get sued, and the hospital's going to get sued when there's a maternal death. I've never seen it not happen. Now, it may not work, okay, but this is the problem. I'm just getting down to the nitty-gritty. The transfer occurs. There's not going to be any communication because there is this animosity in it, and I hope to God it changes. I don't have any. I really personally it's okay. I think if you have lay midwives you work with and you're backing them, that's a perfect situation. Okay, but that's not happening everywhere, and we all know it. Okay. It's just not happening, and it would be great if it did. If we all, like every doctor had, say you knew there was 50 nurse midwives in town, and you divided them up, and that's your person that you deal with. You back them up, or this group backs them up. That would be perfect, but it's not. And you don't have backup, and it's our liability. So that's my big question. So. Are we equalizing everybody, whether they have formal training or not? You're not the people who don't have boards and people who have gone through this extensive master's level training, and we're making everybody equal. Why are you doing that? Not that there's not lay midwives out there that are very, very good and can do better than obstetricians. I'm sure there are. We have boards in every specialty, even out of medicine, that are make things standardized so that people get standardized care, whether it's a lawyer to take boards, because you have to have a standard amount of knowledge to take care of law things, and medical people have boards, so there's a standard thing that you have to know to take care of people. And nurse midwives have boards, and electricians probably have to pass a test, and it's so that they can wire people's homes safely. You can't just go and follow somebody around and say, well, I can do it. I've been doing it for 2 years. There's certain things you got to know. And there's certain standards, minimum standards, that we need to know that people know before they do this. So why are we equalizing everybody? I don't think there's a problem with lay midwives, especially if it's done and promoted and we have these boards and this is how you're going to do it, and you have to go through these steps. And who has the liability? Okay? That is a big issue here. And it's never going to be okay to solve the liability issue. Okay? Because I'm going to be very nice and say, but the word is they're dumped in the ER and then they're a problem. Okay? But it can be nicer than that. It doesn't have to be a dumping situation. It can be a home delivery transfer. But there ought to be some liability involved on the person's part. You can't practice obstetrics in this state without medical liability insurance. So why are we letting this happen? Okay? The nurse midwives need to either have liability insurance if they're going to do this, or a minimum amount, or there needs to be a good Samaritan law that applies to the obstetrician who takes over the care at that point. If that happens, you're going to have the home delivery transfer, not the dumping. You're going to have exchange of information, and I suspect you will have a better feelings towards the lay midwives in the communities. Okay? But we're just getting down to honesty. You're taking the thing that has driven obstetricians out of states. I mean, look at Pennsylvania. Look at West Virginia. You can't even go to obstetrician West Virginia. Okay? Pennsylvania's almost got nothing left. And it's all because of the liability. Okay? I mean, it's the number one thing that people don't go into obstetrics anymore. Is because of this. So we're getting down to the honesty part. Okay? I mean, I've been extremely honest. I've been open. I'm giving you my personal feelings about this. You know, how actually I feel about it. I don't want a home delivery. I can tell you I don't feel good about home deliveries because I've always been told it's better to be in a hospital, and the things that bad happen in a hospital, I can fix them because you're right there and I can fix it. And we're fixers. He can tell you too. We're fixers, and I think you ought to be. I think you ought to be either a nurse or you have the standard. Everybody needs to have the standard training, and the liability issue is going to make or break this for us. But I think if that's fixed, you're going to see a little more acceptance. Any questions? That's it. I'll be glad to take questions. And
thank you. I'm just curious, have you ever been at a home birth?
Have I ever been at a home birth? No.
Oh. When she asked it for the committee, because we don't want it to be a free-for-all situation. But you can maybe tell a committee member they can ask for you, okay? All right. Well, I was just wondering, I knew you were here. Were you here last week?
No.
Okay. Last week we sort of... last week what we did is we sort of began to sort of look at some of the issues you were talking about as far as not necessarily equalization. So first thing I want to say to you, I think I can speak for the committee when I say we're not necessarily, our charge as a study committee is not necessarily to equalize. We want to be sure that we say that. But we do think that there are some, when myself and Stephanie sort of laid out the words of the study committee, we were very particular as to what we were saying. And what we thought is there may be some common things that could be worked on. There were people who had come to us specifically that wanted some issues, some certifications. There were others that wanted to make sure that the whole practice of home birth was not considered illegal in Georgia, and that midwives just automatically, would not be rushed off into jail. And so that was some concerns. One thing I do know is that there seemed to be good agreement on the fact that maybe there might need to be, just from what your presentation, I like what you said about some of the issues around standardized definitions, and so I looked at that. Also, the issue of formal education, as one committee member, I have a little bit different view in terms of formal education, because I know that some people have formal education, and basically they are taught in life. People can teach you a certain way, and once you get that in your head, that's who you are. But there are other people who basically go through life and they have life experiences, and life experiences have taken them as far. Like, say, for this case, let's get an example. Maybe not a good example, but an example. Like Bill Gates didn't have formal education. He started, but he quit. But then in the end, he had enough education to be a trillionaire, whatever, and give money all over the world to people, helping all kinds of things. But he didn't have what we would call formal education to be an entrepreneur, a businessman, or electrician, or all the things you have to do to be who he is. But then the other thing I had a concern about, I know in Georgia, because Georgia, they have some people who they call magistrates. But you would think a magistrate, that means like a judge, would have to be a lawyer. But there are some places in Georgia where people are magistrates, they're not lawyers. So there are certain dynamics of people that do certain things. You probably going to have to let me finish this, I interrupt. So in other words, and then the last thing I want to put in the record, because what we don't want to do is, I love your presentation though, but what we don't want to do is fill people up with fear, because ultimately fear takes over everything. It'll shift the spirit of a room, it'll do anything. Fear. And and so what it is that there may be things that we don't know, but even with at least me with my own spiritual self, it's a lot of things I may have apprehensions and maybe have some fear, but I still do it anyway, because I have to do it anyway because I got to trust that there's a higher power also working in the midst of all that we're doing. And then the last thing I want to put on the table was, sometimes I want to give you an example. Illegal is not always immoral. And the thing to give you an example on that is panhandling. In the city of Atlanta, it says illegal to panhandle, to ask people for money for alms. But the Bible says clearly you can ask people for money, because that's what the Bible was about, helping and that type of thing. But then you could say then everything immoral is not always illegal, because in the state of Georgia, they can foreclose on your house in 37 days. That seems to be pretty immoral to me. They can take your house in 37 days on the steps of the courthouse. But it's illegal for them to do it. So that's the dynamics I want to say too. But I want to keep coming back to the fact that you also said something good around the fact that you said, I think you said that midwives should not be necessarily criminalized if they have to do a transfer to a hospital or whatever. And then you talked about the Good Samaritan Law. So we wrote that down. So that may be an issue that we can look at and see whether or not, because liability is an issue that affects you as obstetrician, but also affects anybody who's actually in the service of it. So I do appreciate your presentation, and what we're going to have to do is sort of, what we're trying to do is get as many thoughts on the table as possible, but ultimately it will have to be the committee itself will have to sort of begin to look at what's been said and sort of scratch in there and see how we can really work it out, that we don't necessarily create an equalized process, but we don't create a process where those people who are quality midwives, whether they be lay midwives, direct interest, CPMs, or certified nurse midwives, that they don't have a climate in Georgia that allows them to put forth a quality product. And so that's my spin on it at the same time, and that's what I'd like to say. Thank you.
Well, I did say formal education, and I don't mean formal education. I mean an education in obstetrics. Not necessarily a medical education in obstetrics, but you don't want an electrician in your house who's never sat down with a book on how to do, or been trained to do that. In this day and age, the information we have is more than we've ever had before. But there ought to be some certain things that are formally introduced in a didactic setting, in a standard board test, whatever you want to do, that we know that the caregivers have this standard information. And it doesn't have to be, it can be a panel of lots of people who decide what this board is, and we already have a board in place. But in this day and age, you should have those basic knowledge in addition to an apprenticeship knowledge that I agree with you is worth millions. It's worth more than any formal education when you have that kind of generation to generation passed down, this is how you do it. But there also are some standard things that we know now that we didn't know even in the 70s and 80s, that it's just the standard of care. Medicine in this 21st century there's enough knowledge that is standardized that if you're going to do this, and if you're going to do the highest liability thing in the country, the thing that is the highest, there's no doctors that have bigger suits than we do. You ought to have that standard knowledge. And
I think there probably is some things that, see, what it is on the last meeting, what we did is we sort of did what concept I call let's break the room up. And what we do when we say let's break the room up as a formal trainer, what we do is we began to really get underneath the issues that's really on people's minds. And what we were able to do is we asked those members who were certified nurse midwives, what problem did they really have, honestly? with certified professional midwives? What's the standard position of their national organization? Are they automatically just against certified professional midwives? And then they stated that they were not. They just they believe in they stated their particular position. Then we asked the certified professional midwives, do you have a problem with lay midwives or whatever? And what is it really? So we can, because after we get all this testimony, at the end of the day, after all the testimony is given, we still have to really get underneath the issues and come up with a solution that will sort of maybe not satisfy everybody, but that will actually still provide the most. See, this is not just about whether the certified professional midwife or the certified nurse midwife. It is about consumers in the state of Georgia having the right to make choices. And you have to give the people the opportunity. And if we as legislators, or if we as members of a body called the Georgia General Assembly have put so many laws in place that have taken away choices, then what we don't want to do is to continue to do it. But at the same time, we do respect the fact that there are some things that we believe that the profession that you have could come together with the fact that of the profession that has always been here, which is birthing babies, and we see it as a normal process. And even though there could be complications, then we also would like to try to figure out a way to minimize the risk. But at the same time, we're not trying to do either or. And we're not either say you got to do hospitals birth or that's it. Or you got to do home births. We just want to give somewhat of a clearing for people to have choices around it, and at the same time, give a level of care in Georgia that is not, whatever. Because in Georgia, we have a standard of care in education, but we 49. So sometimes even our standard of care may not be the level that it needs to be. So we want to look at it and see if we can bring it up, but we also don't want to stop people who have made a contribution. Because one thing you said too is that it was 4-1, and I thought it was even more disparity in terms of infant mortality in the African American community. So even that alone will say to you is that something is going wrong in our community that's apparently, ever with formal, ever with training, ever what's going on in medicine, has not caught that 4-1 ratio. And if we can figure out anything, whether it's reintroducing midwives into maternal care, that might be able to knock that 4-1 infant mortality rate down among African Americans who make up 30% of the population in Georgia, then maybe there's a role for midwives to play in that. But there's clearly a role of that midwives can play in maternal care that could maybe help with infant mortality in other areas where there's disproportion. In the past, last week's also talked about how the fact that they used to have granny midwives all throughout Georgia, because it wasn't like some professions come up because there's a need, not because you get up one day and want to be a midwife. The real deal is in rural Georgia and throughout the United States, there were places that you could not, as a black person, go to a hospital and get care. Either you didn't have money, you didn't have insurance, or it wasn't one close enough. So granny midwives came in and fill a void, and then they came in to help the midwives bring themselves up, like you say, to a certain standard, whatever. And yet and then after a while, in '76, they stopped certifying those what we would call lay midwives, whatever, in 1976 in Georgia. But the real deal is still there will always be women who would deliver babies that won't have none of what you have, won't have what Debbie have, won't have what the certified nurse midwife have. And unfortunately, that's just the reality of it. If you're in a situation you don't have access to a hospital, you don't have what you need, you're going to steal. The baby's going to come. The baby's going to come. And you just got to hope that when the baby comes, that you have some people around who have at least knowledge of sanitary care and all the different things, and a lot of prayer and whatever, and that because the baby's going to come. So what we're trying to say is I don't think that midwives just came up, I want to be, maybe after the first generation of midwives, people began to say I want to be a midwife, but originally midwifery came up because it was a need and it was a vacancy that midwives, community people came in and take it and handled. And even though we know that the number one, like you said, death was with babies, whatever, a lot of it was in the old days. Used to be a time a doctor and it's just my thought, I don't know if it's all actual, but I've heard that in the old days, a doctor who may have actually, the doctor did a lot of things. He did the death, he did make sure the person who died was situated, and he made sure the lady had a baby. And sometime between the person going downstairs to deal with the person who died and the person coming upstairs, they forgot to wash their hand. As simple as washing their hands. Okay, which is a level of, that's why this washing your hand is as important today as it was yesterday, and more important today. So sometimes just that washing of the hand, which would remove whatever that dead person's corpse had, being transferred into the woman's whatever, that was a change. So it wasn't just that midwife service was so bad, and when the nurses and the professionals came in, everything went good. It was something around what was going on with the standard of care, even with doctors who were medical doctors and actually delivering babies. So, we want to be open, but at the same time, I know myself as an author, and my other co-author had to leave, but we just want you to know that what we were thinking, what was the thought when we came up with the legislation. It wasn't to equalize, and so we're hoping that with some of the things that you have said will be incorporated into what we're trying to do. And it's just going to have to be a give or take among the committee members as to how it really plays itself out. We may come up with one piece of legislation, two pieces of legislation, three pieces of legislation, or no piece of legislation. But we are at least trying to see what we can do to help citizens in the state of Georgia have a quality of care and at the same time have choices. Thank you. Any more questions? Anybody have any questions of the committee? Did she give you a question? Okay. Talk, baby, please.
Greetings. What we're looking for is creating favorable conditions to minimize the risk factors and preparing grounds for growth and development and early development of lifestyle changes for a healthier Georgia, and creating a partnership with healthcare providers. So we're looking to work together, not to say, oh, we hate, OBGYN. No, we're looking to work together because we have something that's on the table that's very, very dear to us as well, and that's babies dying, and that's the infant mortality rates that are in Georgia. So we're looking, and then healthy babies can be born, and then if there are any risk factors, we're looking to work together along with you as that follow-up insert to help and make sure that parents, be able to do the things that they need to do in between, the time of whatever prenatal care they'll get from you or whatever prenatal care they'll get from us. But just being able to know that these are the things that you need to look for, because when you look at the risk factors, then you see, number one, then those are the things that we feel we can also play a part in along with what's there already, because what's there already are bringing the numbers out for what we see. So we're only looking to work together with you. Midwives,
Are you a lay midwife, or what's the situation?
Direct entry, or you can say lay midwife. Direct entry for me is directly entered through the granny midwives, which has been here a long time. And if you stop taking so much control of the births when they come to you, like, you have so much control, just release it a little bit so that you don't feel as if it's just all yours. When midwives have been around for quite some time. And we're just looking to work together. We're looking to work together.
Thank you. All right, we're moving on. You anything? Okay. The next speaker, now I just heard, what about somebody has a plane to catch? Yes, Doctor. Okay, Doctor, okay. It's the representative from the Georgia Hospital Association here? Okay, all right. Do you have any flexibility? Okay, thank you very much. Dr. Rayner, you have any flexibility? Okay. All right. Okay, what I want to do is have Debbie to introduce our next speaker, and then the next person will be Dr. Rayner, and then we'll go with will end up with the representative from the Georgia Hospital Association. I need your name, but the Georgia Hospital Association, okay?
Dr. Marsden Wagner flew in this morning from Washington, D.C. to speak. He was a chief resident physician in pediatrics at UCLA. He's past doctoral fellow of National Institute of Health in perinatology, obstetrics, and neonatology, and perinatal epidemiology at the UCLA Schools of Medicine and Public Health. Had his postgraduate degree in perinatology, perinatal epidemiology, and reproductive science at UCLA. For 15 years was the director of women's and children's health with the World Health Organization, responsible for women and children's health in 45 industrialized countries. Most recently, UCLA named Dr. Wagner as a Medical Alumnus of the Year. So we're glad to have him here.
Thank you. I'm delighted to be here. I want to speak about whether or not midwives are safe, or as safe, less safe than obstetricians, as safe, more safe than obstetricians. And to do this, I think we need to look at the scientific evidence, because there's an awful lot of feeling and opinion, but we need to look at the scientific evidence. A study was done of all births in the United States in a year, and they took all of the births that were low risk. Because with high risk births, of course you want the obstetrician. That's what obstetricians are for. That's what they are uniquely qualified to take care of. But they looked at the low risk birth. And then they divided it into low risk birth attended by midwives or attended by physicians. And they found that there was 33% more neonatal mortality, 33% more dead newborn babies in the group that was attended by the physicians than in the group that was attended by the midwives. The midwives were safer for these women. And this was related to the amount of unnecessary interventions that were done by the doctors compared to the nurses. The doctors were doing more induction with powerful drugs and more epidural for anesthesia, more Cesarean, and so forth. All of these carry risks of dead women and dead babies. Cesarean section has over twice the risk of that the woman will die, even if it is not an emergency cesarean, but an elective cesarean. It's twice as likely the woman will die, and there are serious risks for the baby as well. And we saw a graph this morning of the maternal mortality in the United States, and the fact that it came down so much in the last 100 years. Well, between 1900 and 1990, it came down dramatically, and it didn't suddenly fall when there was movement of the birth from the home to the hospital. That wasn't what made it fall. In fact, the scientists who have studied why there were fewer dead women and fewer dead babies determined that it was due mainly not to what doctors and hospitals and medical people do. It was due to things like family planning. So instead of having 10 or 12 babies, you had only 1 or 2 babies, and you had them at the time you wanted to have them. That was the most important reason that these mortality rates came down. It was better housing. It was better nutrition. These kinds of things. Now, about 1/4 of the reason that there are fewer dead women and babies is because of the medical activities. But It is not place of birth. No. It is antibiotics, safe blood transfusion, these kinds of very basic improvements in medical care that caused the fall in the mortality of women and the mortality of babies. So it had nothing to do with home birth. Nothing. And indeed, the other chairman who had to leave asked about what was the situation with regard to the infant mortality and the neonatal mortality and the maternal mortality in Europe. Well, as a matter of fact, the United States is 15th in the world with maternal mortality. There are 14 other countries that lose fewer women around the time of birth than we do. And in every one of the countries that is losing fewer babies, it is midwives, not doctors, who assist at the low-risk birth. One of the countries that has a lower maternal mortality and neonatal mortality is a European country called the Netherlands. And in the Netherlands, 1/3 of all birth is planned and takes place at home. 1/3. And they lose fewer women and fewer babies than we do. And at the home, it's with the midwife. So there is lots of scientific facts that show that home birth with a midwife for those women who are at low risk is a perfectly safe option. And there was mention made of a British Medical Journal study that was done. And as a matter of fact, speaking now, not only as a perinatologist, but as an epidemiologist and scientist, I can tell you that that study has excellent scientific qualifications and methodologies. It is an excellent, excellent study, and it leaves absolutely no doubt that for those 5,000 women in the U.S. and Canada who chose to have a planned home birth with not a nurse midwife, no, with a non-nurse direct entry certified professional midwife. And those 5,000 women had as safe an outcome as has ever been shown to be an outcome in a hospital with doctors and nurses. So it simply adds to the mass of scientific evidence that shows that if Georgia wants to have legislation to permit planned home birth with non-nurse midwives, this is a perfectly safe option, and you are still protecting the people of your state. Over half of the states in our country now have such legislation. And I do not believe that all of the representatives of the people in all of those state legislatures somehow had the wool pulled over their eyes. No. These are intelligent people who looked at the situation and determined that this was a safe option for their people, and so passed a legislation to make it possible. And it is very important to have such legislation, because at the end of the day, it's not about safety. It's about the freedom of the people to have choice about how they want to live their lives. And having a baby is one of the most important things that will ever happen in the life of the family. And it belongs to the family. It doesn't belong to us doctors or the legislature or the midwives. It belongs to the people and the families. And we must honor the sanctity of the family. And that is why the state of Georgia needs to join with all the other states that honor this freedom and this family sanctity and provide this perfectly safe option for the women in this state.
Oh, question for you. I thought you were going to talk some more. Okay.
Well, I would be very happy to
No.
take questions.
No. All right, I just want to make sure, is there any committee members would like to ask any questions? I'm going to do something.
I did forget to say one thing. I'm sorry, thank you. There was a table that showed the maternal mortality between 1900 and 1990 and showed how it came down. This table stopped at that point. What has happened to the maternal mortality in the United States in the last 15 years? It has gone up every year. And we are no longer improving maternal mortality. It's the opposite. It goes up, up, up. Now, why? What is going on? Well, the causes of the maternal mortality were also listed, and it included things like embolism and hemorrhage and infection. Now, those things happen in the hospital, and they are often the result of what is done to them in the hospital. We now know scientifically from excellent research that if you induce labor with these powerful drugs, you increase the risk that there will be an embolism in the woman. It's called an amniotic fluid embolism, and it has a very high mortality for the woman and for her baby. And do you know that there is now 40% of all birth in hospital in the United States today is with induction? There's none in the home birth. Now, as you all know, the cesarean section rate in the last 15 years has gone up and up and up every year. It's now over 30%. And embolism and hemorrhage and infection happens with cesarean. 1/4 of all cesarean in this country, the woman ends up with an infection in the hospital, a hospital-acquired infection. 1/4 of all cesareans. So it is, in fact, what we are doing in the hospital with our increasing interventions in low-risk birth that is resulting in the fact that we are getting more and more women dying in this country. So a woman and her family that should choose to have a planned home birth do not seem to need to be defined as crazy, or in fact they have a lot of important valid reasons why, other than their personal reasons, why they would want to choose to not go to the hospital to have their baby.
What I want to say I'm sort of, let me just put this, okay, I'm going to do this, y'all bear with me, a little different approach. What I want to know is, not for a debate, But since we do have, it seems as if, it looks as if sort of what you're saying and what the other doctor's saying is a little bit different. So just so that it won't be like you're the last word on it, but even though we do have another physician to speak. But still, is there anything, Dr. Gallop, as president of the Georgia OB/GYN Society, that you would like to say, not necessarily to him, but just to put into space as well? Because, since they seem your views were sort of different. Okay.
A couple of things. My chart was not complete. I've been pretty much up since Friday morning and got on a plane this morning, and I couldn't find it all. So I was looking at the trends, which is why the maternal mortality chart wasn't complete. But I was on the internet looking at MMWR and CDC data from about 1 to 4, and I couldn't find the exact numbers, which are delayed by several years. And actually, we have somebody here from the March of Dimes who can probably fill us in on the exact data, but I couldn't find it. I think that submitting our data, hard copy data, for both of us for what we've said is very reasonable, because, you have two doctors here with a little bit differing views, and as long as we both have the data to submit to you so you can look at it yourselves, I think that's very reasonable. Knowing also that you can find data to support just about anything. The induction rates in hospitals are very high, but just like you all want a choice, okay, most of the women who come to us, which are different than the women who go to lay midwives, okay, have a choice too. And they can, okay? And I'll give you that. In fact, I think that's the biggest thing that we can agree on here about this one issue, okay? 90% of the women in Brazil have cesarean sections electively because they just want them, okay? They want them because they think that they're not going to have pelvic organ prolapse and that kind of thing. And that's just what's happening, whether it's good or bad. Women want inductions. They want inductions, and they get them. They can get them. That's fine. Women want C-sections. They can come in and have C-sections. But there is plenty of data out there that elective C-sections and elective inductions have no increased risk. Okay? There is. The inductions.
All right, crowd. All right. Calm down.
The inductions do have increased risks of C-sections and the complications that go with that. Okay? Absolutely. I'm not here to give you bad information, but there is a very high induction rate, and there's very high C-section rates, and a lot of it is because of choices as well. And I will submit my data. Okay. Like I said, I couldn't find the maternal mortality rates for the last 10 years in a hard number,
yes,
despite looking for a long period of time, and I just had time constraints. So I will submit my data, and maybe the person from the March of Dimes probably has it at her fingertips, and we can go from there. But it is a choice. It's a different choice.
Yes. Okay. Thank you. And then that'll be it, because we got to go to our next speaker.
In Brazil, the obstetricians have been saying for years and years and years that they're doing all of this humongous amount of cesarean because it's what the women want. Then, finally, a group of excellent scientists in Brazil did a survey all across Brazil, asking women whether or not they wanted cesarean, whether they got it, whether they were glad they got it or didn't get it. And you know what they found? They found that the women in Brazil do not want cesarean. That was the doctors. And this paper is published. now in the Lancet, a medical journal. The women didn't want it. The doctors wanted it and told the woman. And one of the problems with choice is it needs to be informed choice. And as a matter of fact, by the way, they've now done a study that shows that 1 in 1,000 American women that were surveyed would choose cesarean. Now, if you inform the women what could happen with pharmacological induction, if you told the woman all the dangers to the baby as well as the dangers to herself, then you would not get all of these women agreeing to the induction. So you have got to have full information on all the true scientifically proven risks of these interventions before they're done.
Okay. All right. Thank you very much. I do appreciate what I would like to do, just as Dr. Gallop has said, if you could get me some, the committee members, some of the background information, sort of statistics and data, I would appreciate that. Thank you very much. All right. Our next speaker will be Dr. Denise Reynolds, Associate Professor at Emory/Grady Hospital. We'll put it back there. Right there. Okay. Thank you very much.
Pass it down to Jennifer until we get ready to sign it for me.
Good morning. I'm going to try to be brief, and to help me do that, because I too am a talker, I actually have a prepared statement to read to keep me on message. But I do need to respond to a couple of things that were just said. And right off the top, the remarks about embolism as one of the leading causes of death, that is thromboembolism. That's a clot. Amniotic fluid embolism is incredibly rare and has never been one of the leading causes of maternal mortality. It is a blood clot, not an amniotic fluid embolus. And in fact, if you look at the rates of what we would call thromboembolic disease or blood clots, that has in the past been associated, there's a higher risk with cesareans. But in fact, the absolute number is somewhere 1 in 100,000. Okay, so it's not something that happens very commonly. That brings me to the other issue about cesarean section. For a long time, it has been true that cesarean is more complicated for moms and babies. There are now at least 3 studies that document that cesarean and vaginal delivery are equally safe. I didn't believe it either. And there's actually a study from Israel that says cesarean is safer than vaginal delivery. Now I have trouble with that, and I also have trouble with doing elective cesareans. But understand that's the data that underpins the willingness for physicians to give women who are asking for elective cesareans the choice. 10 years ago, no physician would let someone come in right off the street and ask for a cesarean section. Didn't happen. I don't want to do them. But, in fact, because women are asking for this, and we now have data to say it's equally safe, physicians are beginning to do it. If you're about choice, women are elected to take that choice. The other comment about cesarean infection rates at 25%, that can't possibly be true. It doesn't make sense. In most hospitals, it needs to be less than 10%. Every hospital has an infection control committee that looks at infection complications for surgery. The trigger point for almost everyone is 15%. So if the cesarean rate across the board were 25%, all of these people would be looking at why is that happening. In our hospital at Grady, it's somewhere around 10 to 12%. And we had, until relatively recently, one of the lowest cesarean section rates in the state. And in fact, 5 years ago, we were definitely the lowest, particularly for a institution of our size doing tertiary care. And then the other comment I had to make was about maternal mortality increasing. Let me go back and look at safety of cesarean section. Much of the reason why cesarean section mortality is lower has to do with differences in anesthesia. Anesthesia and anesthesia-related complications from general anesthesia has been one of the leading causes of maternal mortality. Right? Now that anesthesia is safer and we're doing regional anesthesia, that's taken a lot of the risk associated with cesarean away. So it does actually make sense that cesarean is a lot safer, and it has a lot to do not with obstetric care, but with anesthesia-related complications. Okay. When we think about having a baby, we all get this warm, fuzzy feeling. And for probably most of the people in this room, they see the birth of a child as a wondrous, happy event. But I suspect there are others in this room who know someone, a friend, a relative, or perhaps their own family, when things didn't go the way they had envisioned. It might have been an early birth with the baby staying in the intensive care unit, or a short or even prolonged neonatal hospitalization for a complication, or a longer stay for a maternal complication. This illustrates an important point. While pregnancy and childbirth are normal natural processes, there are many places where it can go wrong along the way. One doesn't have to look back too far in our history to remember that pregnancy and childbirth were life-threatening for women and babies, as we've already talked about. And of course, this is not a historical fact, since in many underdeveloped countries, maternal mortality is 200 to 500 per 1,000 live births, or 2 to 5 per 1,000 if we get rid of some of the zeros. Now, I don't want to sound like a purveyor of doom and gloom, for the majority of births in this country annually go well, and even those with complications have an acceptable outcome. I mean, delivering babies doesn't have to be all that complicated, because even taxi drivers can do it. Babies pretty much come when they want to, whether there's someone there to catch them or not. But things can go badly, sometimes very badly, literally in the blink of an eye. And that's when the expertise in diagnose and treat the problem in a critical window can prevent sometimes irreversible harm to baby, mom, and both. Recent trends in obstetrical practice reflect changes in the patient population as well as public attitudes towards surgery. As more women delay childbearing, there's increasing demand for assisted reproductive technology. The general acceptance of reproductive technologies parallels a decline in the interest in natural approaches to childbirth. The majority of women today seem to want to eliminate much of the uncertainty in the process, and the response in the obstetric community has been rising rates of elective labor inductions, which has led to more intervention and higher cesarean rates. I will say that in many hospitals, though, there is an informed consent that is done before elective inductions, and it's signed, right? So women do have an opportunity to understand the complications that are associated with inductions. But I can tell you, I have women who ask me all the time to have an induction. I'm not big on doing elective inductions either. And I talk to them about it, but that's what they want. Improvements in the safety of surgery, coupled with the popularity of elective surgery as the fountain of youth, the solution to perceived flaws in appearance or weight loss, has spawned a patient demand for elective cesareans to which many physicians have acceded. I will say to you that in Brazil, one of the reasons why women were elected to have cesareans is it meant that they could have births in the hospital. And there is a very big difference between infant and neonatal mortality in births in Brazil outside of the hospital than in. So many of the women who were opting in were really opting in to have a hospital birth, and there is also a study that supports that information. For changes also in the indications for cesareans, like breech presentations, because we now have very good evidence worldwide that breech does have a higher risk of neonatal death when done vaginally. I say to you, there is good evidence. There is good evidence, right? We all weigh the evidence. And trust me, I've done tons of vaginal breech deliveries in my career, and I believed and supported them. But I also know, because I teach residents, they don't have the expertise to do them very well at this point in time. We are a far cry from the 70s and 80s, when many women sought a natural childbirth experience. Today, for women who do want to go into labor, the majority want a pain-free experience with epidural anesthesia and all the associated medical interventions. We do have a consumer-driven society that responds to, and I'll admit in some cases, creates demands for products. Be that as it may, the response of many hospitals has been to create a more homey atmosphere in their labor rooms with wood floors and medical equipment hidden in wooden cabinets. Certified nurse midwives who work in these settings help develop birth plans and provide more personalized care throughout labor. But they also have access to physicians to perform cesareans for arrested labor and, importantly, immediate assistance for emergency. Let me say that, personally, I have long supported the practice of midwifery. Before I was a medical practitioner, I gave birth to my daughter under midwife care in the birthing center in New York City. I chose a birthing center because of the horrendous hospital experience I had with the birth of my first son in 1975, when my husband was denied promised entry to the delivery room, and I had to argue between pushing with the house physician who wanted to give me sedation, which I absolutely did not want. My medical practice with midwives dates back to third-year medical student clerkship at Vanderbilt, and I was an active participant in a group fighting for nurse midwives to practice independently with physician backup in Tennessee. I continue to enjoy practicing at Grady with the Emory Group of Certified Nurse Midwives and participate in the discussions that create the practice agreement. I have even established inclusion of the group prenatal care model provided by midwives at Grady into the resident training curriculum so that now our residents participate in the groups. Thank you. So what about those women, a small minority, who want to plan a birth with midwife care in a comfortable setting without analgesia? I would say that there are providers with whom a full range of women can feel comfortable. Obstetrics is increasingly female, with some training programs now 100% female. In addition, There is a full spectrum of ethnic, religious, and cultural diversity in our subspecialty, as well as a philosophical approaches to care. And I think you may have even seen that in terms of differences in testimony here. In some cases, it is still possible to have a comfortable experience with certified nurse midwives in the hospital. A birthing center with rapid access to emergency care represents an attractive alternative. Home birth may incur additional risk, even for appropriately selected patients. There are a number of significant issues that need to be addressed. Practitioner Certification. In short, the state licenses physicians to practice. Midwives should be regulated as well, since they too practice medicine with the delivery of prenatal care and must interact with medical professionals with whom they need to communicate and so need to be conversant with medical terminology for good transfer of care. Patient selection is also critical. Only low-risk patients without medical illness or pregnancy-related complications should consider out-of-hospital delivery. Obstetric history of complications such as preeclampsia or delivery, or commonly known as toxemia, or delivery before 37 weeks of gestation, and even abruption carry a risk of recurrence, and newborns may require hospital care. Risk assessment should occur on an ongoing basis during prenatal care. Physician involvement is important in risk assessment for referral for further testing and diagnosis, and to provide care for those who are no longer appropriate for out-of-hospital care. An established relation with physicians can help ensure that patients will get adequate evaluations that are communicated to the midwife, and that those who are, quote, risk out, end quote, will have physicians with whom they are comfortable to continue prenatal care and ultimately delivery. Fetal risk assessment is also critical. The standard serum screening for genetic abnormalities can also identify fetuses who may have additional risk for complications, such as poor fetal growth, and need adjunctive neonatal care. Ultrasound screening can identify multiple gestations and congenital anomalies, such as congenital heart disease or spina bifida, to name some of the more common problems. These will also require additional neonatal care. Bear in mind that 1 to 3% of pregnancies are complicated by congenital abnormalities, and this cannot be considered rare. Women who develop pregnancy complications in later gestation, such as preterm labor and/or premature rupture of membranes, and preeclampsia, which require hospital care, should have the availability of physicians with established relationships with midwives to provide the optimal transition to in-hospital care. Currently, premature delivery occurs in more than 10% of pregnancies in the United States, and that's about 500,000 babies a year, and premature labor is even more common. Preeclampsia, which occurs in 7 to 10% of pregnancies, can cause seizures, stroke, bleeding, and other severe complications. Treatment is generally delivery, and preeclampsia remains a leading cause of both maternal and neonatal death worldwide. Unfortunately, we are still not able to predict which women will develop these complications, and they can occur without warning. Obstetric complications can occur during labor, and some are emergencies that require an immediate response. Response times to the emergency can be the difference between life and death. Some examples are umbilical cord prolapse, placental abruption, obstetric hemorrhage. Each of these occur quickly without warning. Care will be compromised when home birth takes place in areas without rapid ambulance response or at significant different distances from hospitals. Here again, women with midwives without ongoing physician backup may arrive at the emergency room, be assigned to a physician, cover the unassigned patients for the day. That physician is not immediately available in-house, wasting critical minutes even further. Of note, in the prospective study of intended home deliveries showing outcomes are not worse than other low-risk deliveries already referred to twice, all 5 newborn deaths during labor could have been prevented with delivery in the hospital with continuous fetal monitoring or cesarean delivery for breech. And 3 of the 6 deaths of normal neonates could have been prevented with neonatal care at delivery. Note also that 12% of the little over 5,400 women were transferred to the hospital, and 3.4% were considered urgent. Before I close, I want to address vaginal birth after cesarean specifically. Otherwise known as VBAC, is not safe outside the hospital. While hemorrhage and injury to other organs such as bowel and bladder occur, the most significant complication is uterine rupture, which can result in neonatal death when all or part of the baby is extruded through the scar into the abdomen that has opened up. Uterine rupture can occur in 5 per 1,000 trials, as documented by a number of studies. While 0.5% seems very low, if it happens to you, it's 100% of your experience. The most common presenting sign in uterine rupture is abnormalities in the continuous electronic fetal heart tracing. This most common sign will be absent in the home setting and may not be apparent with intermittent listening to the fetal heart rate. In addition, a high index of suspicion is critical for early diagnosis. Continued pushing with contractions can extend the uterine opening, increasing the chance of injury to maternal organs as well as risk to the neonate. Current American College guidelines require hospitals to have 24-hour anesthesia and a physician in the hospital in order to perform VBACs, all to be able to perform cesarean expeditiously. The change in guidelines was a response to poor maternal and neonatal outcomes with uterine rupture in hospitals with delayed diagnosis when physicians were not present or cesarean could not be done in a timely manner. My own personal experience delivering a baby found floating under the mother's liver in the abdomen at the time of C-section, with both mother and baby alive and well at the end of the procedure, is convincing evidence that rapid response can make a critical difference. One of the authors, Tom Easterling, of that Sentinel study on VBACs in Washington State, published in the New England Journal in 2001, which I believe has also been talked about here, risk of uterine rupture during labor among women with prior cesarean section, told me that he was galvanized to do the study because of his experience with the disastrous outcome of women attempting home VBACs in his home state of Washington. As he put it, he just couldn't see why we should take any chance that a healthy baby should die unnecessarily. Can women deliver safely at home? Sure. Unintended home deliveries are not infrequent occurrences. Does it follow that some women can prepare to deliver at home and have a successful birth experience? The question comes down to, at what cost? The state charged with protecting its citizens should not support a policy that will place any woman or child at unnecessary risk for injury and death. It is not in the interest of the state of Georgia to encourage women to take unnecessary risk with the lives of their newborns. Is it reasonable for women to have a choice? Probably. And what we should do is try to create a system where the choice can optimize the outcome for every woman. Now, there's been a lot of talk about, well, Europe and the Netherlands, and they have lower maternal mortality, and actually they have lower neonatal mortality as well. In those areas, the system is very different. Midwife and home birth are an integral part of those systems, and they have tremendous processes to respond to emergencies and to also provide support, ongoing support for women who deliver at home. There's the setting where women are initially assessed, and they're allowed, and they are either kept in the system for physician or high-risk management, or they're allowed to go and deliver with midwives in either the hospital setting or to have home births. That's a very, very, very different setting than what we have here. And we would need to establish much better communication and ways to get women who may be delivering in hospitals distant, in homes distant from hospital, or in places where the ambulance response time is prolonged. Those are the women we need to find ways to get them to enter into the system with fairly rapid flow and communication, so everyone's on the same page, knows what the problem is with the patient, and can deal with it fairly quickly.
Thank you very much. Any member of the committee have any questions?
I actually have a couple. One of the things I heard you say, thank you for speaking, by the way. One of the things I heard you say earlier was that you felt like birth centers were safer than home births?
No, actually I didn't say that. Well, I said that I think that birth centers are an attractive alternative, because they do, in general, have that ability to get rapid in access into the system in response to emergencies.
So if there's a midwife who actually is working in a home birth setting and has a physician backup that's meeting her and she can get the patient to the hospital, that'd be sort of the same thing, is that what?
Potentially, yes. I mean, there are some things where transport can't help.
Right.
You know, if you have a cord prolapse,
right,
the baby's probably going to die.
And
if you have to go anywhere other than right down the hall to get a C-section.
Well, and one of the questions about
doesn't always happen.
5 deaths you were talking about, I was wondering, any of these situations, was it specified that these cord prolapses were in labor, or were they?
No, these were all intrapartum deaths from that study. 1 was a cord prolapse, 2 were vaginal breaches, and now I'm blocking on the other. No, it's the intrapartum deaths were not related to hemorrhage.
No, I mean the cephalic or the.
Oh yeah, bleed. Was the subgaleal bleed, and that one is maybe questionable. However, in general, that usually will present with abnormal fetal heart tones that may have allowed you to pick that up in the setting of continuous monitoring.
I think one of my things was with that cord prolapse, I believe, more the situation was that the cord
was undiagnosed
prior to the midwife's arrival. They're transporting.
Right. But again, I mean, that's just the difference between.
And that can happen to someone going to the hospital
yes,
as well.
You're right.
That's what I was trying to get through.
If someone comes later into labor, what would happen is you put the monitor on and go, whoops, there's a bradycardia here. Let's just roll on back to the.
Or it's beyond.
To C-section, right. Or there's no response at all.
I just want to make sure.
I said could have been. I didn't say
I just want to make
were.
sure that everybody understood that can happen.
Oh, sure.
Yeah.
I mean, bad things happen.
Right.
Even in the hospital, bad things happen. Right?
Yeah.
Any other? Doctor? Anything say? Anything say? Okay. All right.
And he has 2 pages of them.
Okay. All right. Thank you. Okay. I would like to request again from Dr. Gallop the PowerPoint, and then I would like to, if you could, get a copy of what you said as well. All right. Thank you.
I can actually provide you with the references. I know there was a lot of, C-section safer, and I'm happy to provide those
Well, that's what I wanted to ask. Can I ask
Yeah.
question?
for anyone who's interested.
On the breech deliveries, I think one of the main things that turned the breech deliveries around was the Canadian study. And the mortality rate, it actually wasn't, the mortality rate wasn't significant, but what they were concerned about is the babies had lower APGARs with vaginal deliveries. Now, from what I've heard recently, they've done the follow-up on those children, and they actually turned out not to be any difference in the babies' IQs and everything now, but they've never, and they made that report saying we were wrong. There isn't a significant difference. But this policy hasn't been turned around.
I think I have to differ somewhat in your conclusions from the study. And we're talking about the study, the randomized control trial that was done worldwide. And actually the woman, actually, no, the focus was not in Canada. So we may be talking about different studies. This was done, some centers were in South America, some were in, it actually came from the UK, was the initiator. Some were done in South America, Africa.
Do you remember the author on that?
I'm pretty sure it's Hannah.
Hannah, that's the one I'm talking about.
And they actually stratified the results to countries that had a high neonatal mortality and those that did not. So they actually looked at the statistical differences between countries that were more developed and had a high base neonatal mortality, and found that actually in both those settings, the neonatal mortality was higher. Now, the follow-up studies that you're talking about say that the children, the differences in neurologic development, there's one about neurologic development, etc., but the problem is it excludes those that died, right? Because they didn't get any follow-up. I would also add that was the final straw, but there are at least 2 studies before that, also very large, both from Scandinavia, that confirmed the same thing. I grew up and did vaginal breaches. I believe they should be done, and I've had a good experience doing them, and I'm confident in my expertise to be able to get out of trouble with them. And I'm sorry to kind of let that go, but I really feel like if we have data that says it might be safer to do something the other way, then why do we want to keep doing something that may have a higher risk? It just doesn't make any sense to me.
Check out those others.
Okay. What I want to do is, just as I did before, there were some things that you said.
Right, that disagreed with what
yes,
you said.
Let's see if there's any follow back up on that. Not necessarily to her, but just put it out with you.
Yes, she's already said something that I wanted to say, and that is that bad things happen, and bad things happen also in the hospital.
Absolutely.
And in fact, studies have shown that around 1/4 of all perinatal deaths were probably preventable. And these were deaths that occurred in the hospital with all the doctors and machines and all the rest. So that we need to try very hard to avoid what I call horror stories. You know, there was a case of this horrible thing that went wrong. Also, it's important, you sort of went through a litany of all of the various kinds of things that could be identified that went wrong. And this is all correct, but it's also true that while all of those things could have gone wrong, if you look at the real world and you look at how many babies and women are dying or having problems elsewhere in the world, you find out that they have been able to manage all of these possible things that could go wrong. And I agree with you that when Georgia legalizes direct entry midwifery in home birth, that will only be the first step, because what needs to evolve is a situation like you described in the Netherlands, where if someone has elected for a home birth, there is already in place a system for referral and transport and whatever else might be needed. But you have to start, and so you start by legalizing these midwives and take it from there.
Okay. All right. Thank you very much. The next speaker, let me just say this. Did y'all notice around 12 o'clock, all the kids started talking? About 12, all of them started, this baby over here started saying, wow. Everybody just started talking. It's almost as if they know at 12 something happens. Usually we leave. But okay. So young people, I hear you. We pushing. All right. So our last presenter besides our community discussion will be the representative from the Georgia Hospital Association. Would you just tell me your name?
I'm Karen Waters.
Okay, Miss Karen Waters. All right. Now, Ms. Waters, I know we asked you specifically about issues around C-section rates, but also I don't know if you have the direct information or not, but one of the other questions that members of the committee had asked about was a question as to what we were trying to do is there was a hypothesis put on the table that maybe at the second meeting, and the hypothesis was that there was a direct relationship between infant mortality. You got the hypothesis? There was a direct relationship in terms of infant mortality rates being lowered if, you know, you should have to read it off the exact words, but the main thing what we want to know is how many hospitals we have in rural Georgia, and are they close to areas where there's high infant mortality rates? I don't know if you have that specific information, but that's what I was trying to get a grip on is where are hospitals at in Georgia, and then we can look at where the hospitals were in Georgia and where the high incidence of infant mortality were, because we thought that there was some relationship between the fact of, you know, if maybe there could be some correlation of what was going on. So that was one of the questions, but we'll talk about that later. Okay, thank you. If you get what I'm saying, trying to get to. All right, thank you very much.
I'm Karen Waters with the Georgia Hospital Association, and I don't have any prepared comments, but I just wanted to make some brief comments. I really appreciate the various physicians who have provided comments today, and I think that you can certainly look to them to provide information to you about the various studies that have been done. They're scientists and certainly can comment on those various studies. The one thing I do think is important, though, for the committee to realize and to focus on, when we talk about a lot of other areas where the state has responsibility for oversight, while they didn't have any oversight for Bill Gates, what he does on a day-to-day basis does not affect the life and safety of individuals. And the regulation of the care provided to moms and babies is certainly important to everyone in our state today. And I don't think that we can make light of that and say it's not a safety issue. I think it really is a safety issue, the bottom line. That's why we have the different regulations in place for the different licensed providers and for the both hospitals and physicians and nurses. It's without that regulation, there would not be that safety that the public perceives. As long as the state has said that we license these individuals, then we have a certain comfort level and belief that what we're going to be receiving in care or whatever provision of services provided is reasonably safe. So I think that that's really important. I don't have data on C-section rates. I know there've been a lot of discussion about that, and if you are going to need some specific information about C-sections, I'll need to have that for us to be able to provide. I know that we've done a lot of work with hospitals, especially in the area of VBAC rates. And one of the things that you've seen the change occur over the last probably 5 to 6 years, maybe longer than that, is an increase or decrease in VBAC rates. I can remember back in the mid to late 90s, there was a lot of emphasis on really trying to increase those VBAC rates. And I think because of the complications that they saw from trying to do that, many of the obstetricians have backed away from doing that. And it is rare that you find, unless the mom insists, and that's then tried in the hospital, it's rarely done. Most of the moms go back to C-sections. I do think it's important, though, to talk about the choice, as the other physicians have mentioned. I have talked even with my own daughter, who had a baby earlier this year, and with many of her friends. And just what you've heard say is really true. Many of these moms are asking for the induction, to be induced. It's not abnormal at all when they talk about that with their physician. They're also asking for the epidurals. It's also, that is a normal part in that with all their friends and so forth. They're in a very much of a childbearing age right now, and most of them, that is their decisions that they're choosing to make. Related to the infant mortality, I do know that we have at least one hospital that I know that has closed in this last few months, and that there is another one that is closing, but they did not provide OB care. I think we've got about 30-some hospitals that provide OB care, and I'm not sure where they're located around the state in order to look at the infant mortality issue in relation to location of hospitals. I don't know whether public health might have that data broken out by the various public health districts that might be available to you to look at more closely related to that. But I think that making sure the mom gets into prenatal care is extremely important, so that there can be a close following and a determination whether there might be a risk there for complications. I think, though, that we would be amiss, though, if you just think that if that's been a low-risk pregnancy, you won't have any problems in the delivery. I was talking to my friend this morning, and she related how her daughter, everything was normal, and she got into the delivery, and it was only when she was actually, the baby was in the delivery canal and being born, that the heart rate dropped, and they had to hurriedly get her out. And she said if she had been at home in a home birth, she knows that situation, she would have not have survived it. And so I think it's just making sure that the families, if the state says this is okay for you to do, that they can trust the state to say that's safe. And that puts a lot of responsibility on the part of the state to make sure that they research and they study to make sure that this is something that is safe for the public before they endorse and regulate that area.
Now, you know what? I'm sort of thrown off a little bit, because now I don't know what the Georgia Hospital Association does. Because basically my co-chair, who had to leave for her son's Christmas party at school, has down that you were going to talk about C-section rates. You state to me that you do not have information on that.
I don't have that with me here today.
Okay. Hold on for a minute. Okay. And then my thought was, when I was requesting the Georgia Hospital Association, I was dealing with issues related to the radius of, identify radius of hospitals in rural counties, identify, I had some other things about where hospitals were located in Georgia. And then you said to me you don't have exactly all of that. So I'm quite not sure whether or not, and then you tell me you did give some good testimony as to what your family members had said. But what I'm trying to say is, so the Hospital Association is not the place that I get information about hospitals in Georgia?
And is the Georgia hospital just not? We just didn't know. We were thinking that they would have information about C-section. And so, in other words, when you were asked to come, what did they tell you were going to present today for us? I'm just trying to understand why.
I think talk about the issue of home delivery is basically it. But
because you know, from the hospital side, you wouldn't be able to talk as much about home delivery because you basically on the hospital side,
right?
But it's okay. So no, my request
is if you will give me some specific questions about what you're looking for related to the C-section rate.
Okay.
And if I did not know anything about that, you wanted to look at specifically where the hospitals were located that provide OB care.
Yes.
You can provide me with that question, and we can certainly respond.
Okay. So what was my co-chair asking about C-section rate? Do we also have that?
What I have is from the Office of Health Information and Policy that has birth to Georgia residences in it.
Package?
Birth to Georgia residents by place of birth, and then it also has C-section births to Georgia residents by place of birth, month, and year.
Okay. Do you have to say that? I mean, I don't need it again if that's it. But I'm asking, does the Georgia Hospital Association collect that information? Would you have been the entity that we need to have spoke on this anyway?
We would have it probably by hospitals, specific C-section rates by hospitals.
Okay. All right. Okay, well, what I'll do is after the meeting, I'll communicate with our research person, and we'll see if there's something specific that we need to ask. You know, are there any questions? Okay. Thank you very much.
You're welcome.
Okay. We're at 12:30. Not that we have a particular time limit, but we just basically have been going for about 10 to about 12:30. However, I wanted to make sure that were any questions among the committee, and then if there are those who from the public that would like to speak, I will open it up for at least 15, 20 minutes, 2 minutes apiece to comment. If y'all would like to, we'll stay longer for that if y'all would like to. But first, I would like to hear from the members of the committee.
Good morning, everyone. We have heard some excellent speakers and presentations this morning from my medical colleagues who I've not had the pleasure of meeting personally, but certainly enjoyed listening to some great comments. For them that don't understand how I came to be on this committee, in the last 18 years of practicing as a private practitioner in the state of Georgia, women come to the office and they state, they don't ask, they simply state that they're probably going to deliver at their home. And they asked me, would I at least be on call for them if they showed up at a hospital? And I felt that ethically and morally that was something I should do. And so what I did was I established I simply established my own medical legal set of standards there where I simply said, do you want this? Do you want this? And then if you don't want labs or you don't want this, but I did insist that they come at least 3 times to the office. At the first trimester, at the second trimester, around 24 weeks, and at the third trimester at 35 to 36 weeks, so I could determine presentation, signs and symptoms of toxemia. That's basically how I came to know a few of the home, whatever you want to call them as they call themselves in the state of Georgia today. Hopefully that may change. I don't know. But that's how I came to be here. It's not that I have a specific opinion or drive, but I think it is important, as Dr. Gallop pointed out, Dr. Rayner pointed out, there's going to be choice in the state. And we have, whether it's informed choice, as Dr. Marsden pointed out, or whatever, women are still going to deliver at home. That's what I've learned from talking with these women, is they're going to deliver at home no matter what the state does unless they define it as a crime. And I don't think they will. On that point, I have some observations, and I'm giving these for Representative Thomas and Benefield as the medical member or the consultant. And that is, as several of our doctor colleagues pointed out this morning, there has to be a formal standardization of terms. This is paramount to to achieve your legislation. Otherwise, you will mire down with numbers and numbers of lobbies and anti-midwife groups coming in, everybody fighting over a term, and that'll be like 8 more years before something happens. Number 2 is that I think it's well established there are numbers of states, border states, sister states, and states throughout the Midwest that have programs that allow some formal training and criteria for a midwife to perform a low-risk vaginal birth. Now, understand, people in this audience here, I think that there's no point in getting into an argument about a breech or a VBAC or toxemia. You are never going to convince me as the medical community or any of my other colleagues that those deliveries are going to be better performed at home. And here's why. Because none of us who do them understand we can't do them where we are today because of medical legal concerns. You can take a poll of every physician in the state of Georgia about breaches, and he's going to tell you, I do them except I get sued if there was one bad result. And if you've ever been sued and ever been there, and I have, and I don't know if Dr. Gallop has or Dr. Rayner, but we don't like it. It is a great distraction to my life as a physician. And that's all I'm going to say about that. Now, choice is your key. When you create legislation, we hope to allow safe choices. However, I caution the legislators and the lobbies for this midwifery that that's a double-edged sword, because once you have legislated yourselves to have permission here, then that perhaps becomes a law or a standard that you yourselves must follow. And when you don't, criminal intent or legislation or overzealous district attorneys may come down hard and heavy, and perhaps even our legal brethren out there that like to sue, the so-called plaintiff's attorney group, which they have the right to in the state. That's fine. I'm not arguing with who they are. We need lawyers, okay? So that is what our legislative people are dealing with right now. It's not about some points that were made today that were somewhat, just more, medical information and stuff. It's all necessary, and any doctor knows that. That's going to happen. But I just hate to see, personally, that there won't be something that allows some safety in the state. And I think if you heard all the speakers, they all said the same thing. We all want some safety here. There's going to be a middle road that you achieve. That's how it's going to come down. And I'm here to help Representative Thomas Benefield. I'll meet with I'm a member of the Georgia OBGYN Society, a member of the American College of OBGYN. Everything that those organizations do is for the safety and health of women in the state of Georgia. I don't think anybody cannot believe that. C-section rates are climbing. Everything you heard today is relatively true. There are a couple of points about high infection rates I also could not agree with on that subject. I mean, I do my own little peer review in my own office in my career of 18 years. What have I done? 500 C-sections? What's my infection rate? It's less than 1%. Well, you can't say I have a 0.25% section rate. I don't. How many breaches have I done in the last 2 years? 15, all C-sections. Because you know why? Because I asked the mother, do you want to attempt a vaginal birth? And I presented the complication rate. And 100% said no. But you out there, I heard some of you saying, oh, no, you can do it at home. You can. You can. But I can't be there and watch it happen. And I don't know if that's really something that's going to come down as a safety factor when you ask laws to be passed by our legislators. So those are the type of points I wanted to make. And then once you set these standards, you have to abide by them by both sides. One of the other problems is going to be this, and I encourage our legislators to listen to this point, because I know that physicians I know Dr. Gallop probably feels this way, Dr. Rayner feels this way, and I'm already participating. But I'm willing to participate. But if you put legislation in place that says midwives can only deliver if they've got a physician backup, I suspect we'll be mired down in 99 physicians saying no and one physician saying yes. Would you agree? That's what's going to happen. So that's the kind of ideas, that's the way I think, and that's the kind of ideas I want to present to the legislators, why I took time out of my practice to be here this morning to say those things, because I'm not really a big legislative guy. I mean, I barely give it to the political action committees. I don't walk downtown when they... Shame. I I don't walk downtown when they have doctors don't want to worry about malpractice. Remember, I told you it's not a malpractice crisis; it's a reimbursement crisis. You can charge me all you want for malpractice. Just pay me so I can get it. And I'll be happy. Thank you very much. You're all a very attendant group. I wish you the best, and I want to let the committee know I won't be here next Thursday. That's my operation day. But if you need any comments from me or need my feedback, please, Dr. Gallop, call. I'm just here as a friend of the court, is what they say.
Any other member of the committee would like to speak? We would like to also let it be known to just name the members of the committee just publicly. The members of the official committee, which was appointed by the Speaker of the House, which is Representative Glenn Richardson, is Dr. John Schilling, Ms. Debbie Pullen, and what the way it was set up is it was have four legislators. It would be myself and Representative Stephanie Stuckey Benefield. Then some of you have met Representative Donna Sheldon, and then there's a representative named Buddy Carter, who actually the birthing center that people are talking about is in his particular area. He just has not been able to make the meetings, but he is the fourth member. You have not seen him as of yet, but he does represent an area that has the birthing center and was very interested in this particular issue. Then we also put in the legislation that it would be an OBGYN also that would be an official part of the committee, and that's Dr. John Schilling. And then we also said that there would be a certified professional midwife as a part of the committee, and that was Ms. Debbie Pullen. And then we also said that it would be either consumer or lay person. And in this case, we have a lay midwife, Ms. Nazra Noor. So you can get the idea of the dynamics of the members of the committee. Thank you. Anybody want to say that? Okay. If not, I'd like to, if anybody from the audience would like to speak, we'll go to 1 o'clock. If y'all would like to have 2 minutes, only 2 minutes if you want to speak. If not, what I want to do is to let you know that the next meeting will be after Christmas. So I want to say Happy Hanukkah, Merry Christmas, and Happy Kwanzaa to you. And the next meeting will be December 28th, and it will be the same location at 10 o'clock. And so we will look forward to seeing you there. We're going to try on the Friday. I mean, the 28th is what day? Thursday. We're going to try to do some wrap up and some discussion work, and to sort of try to put it in. But I think it's important what you just heard from Dr. Schilling, because there are many people who just want legislation. But let me just tell you this, once you are getting legislation, you are in another dynamics, because then you have to be, you can be strongly regulated by that legislation, as well as the fact, as has been stated, there could be there are 159 counties in Georgia, so there's a lot of DAs, district attorneys, and if something happens, they prosecute accordingly to who they are. They have a standard of care too, but then there are some who are more zealous than others as well. And my intent as an author of the legislation is not to try to send people to jail. There's enough people in jail in Georgia, so we're not trying to add, mothers and and midwives in that setting. So now there might be other people who would love to do that, to criminalize everything, and so we're in a law and order state. But at the same time, what we're trying to do is to put forth legislation that does try to satisfy the level of safety that we're talking about. But at the same time, it could be, and I don't want to throw y'all off the track, but it could be we may say, well, at this time, maybe we won't put anything in this section. So what it is, you got to remember, we have 2 years. We have 2 years. We have this year. We were elected for 2 years. We might say that we need to spend the rest of next year working through some of the support system stuff that was talked about by Dr. Denise Reynolds and also Dr. Wagner. We may say, well, if we go to this type of services we want to go to, how do we put support system in place? So I'm just saying it's not like we have to come out of this committee with a piece of legislation, but you do know that but there is two cycles. There'll be this year's cycle, and then next year's cycle might be when we come back with legislation. I'm just letting you know it ain't just it got to come out for us to put something in January. We still have some flexibility because it's a 2-year term, and we can do it in the next term as well. So I'm just sort of putting that out there so everybody don't feel like locked into something. I ask you to be open and flexible, and to see whether we can come out with a quality product. And we won't probably get 100% agreement, but we do want to make sure there's some level of choice, informed choice, as well as the issue of safety is one that's going to drive a lot of this as well. Thank you. Any speakers? Okay. Give me a list right quick. We can sign up. Okay, 2 minutes, y'all. I know you 2 minutes, and then so come on to the mic. Give me your name, but you got to get signed up. John, you have a lead?
Okay, thank you. Great. Okay. We'll sit down there. We'll get your sign-in sheet.
We'll get your sign-in sheet so we can get your name and address, at least phone number, email, so we can communicate with you. All right, 2 minutes, y'all. 1 o'clock, we're going to rock and roll out. Okay, thank you.
My name is Michelle Stilley. I'm 22 years old, and my husband and I are expecting our first child next June. I just wanted to respond to something that was said today that really bothered me. Several people said this, that it's the state's responsibility to make sure that women make choices that are safe for them. Well, on behalf of my family, my husband who is here and my mother who is also here, I would like to say that we believe that it is the state's responsibility to protect my choice to make whatever choice I want to make about my own body. It's the state's responsibility to protect my choices, not to do what they think is right for me. I'd like to give two comparisons. One is abortion. I personally believe that abortion is wrong. I believe that it's immoral. But I also believe that it's immoral for me to make that choice for other people. I believe people should be able to make that choice for themselves. I also believe that it is wrong for the state to tell families how their children should be educated. I received no formal education until I was 10 years old. I couldn't read until I was 10 years old. My mother knew what was best for me. The government didn't want us doing that, but we did it anyway. This May, I'll graduate from Georgia Tech with a Bachelor of Science in Mechanical Engineering. So I turned out all right. Thank you.
Sign-in sheet. So you got one, but he needs to sit at the table and not move with the person. All right, thank you. Appreciate it. Identify yourself and then we'll go for it.
My name is Mrs. Debbie Sapp. I'm a direct entry midwife, and I'd like to speak to just a few of the points, and I'll try to go as fast as I can. One of the points...
Let's turn on. Yes.
One of the points that was made was that we need to get the women into the hospital. We need to get them prenatal care. However, a lot of the studies have shown that women who receive prenatal care really aren't doing as much better unless they have a lot of nutritional counseling, and they have a lot of counseling on how to change their behaviors to do better. And I think that home birth midwifery would do that. Another statement was made that hemorrhage and infection cannot be handled in the home setting, yet home birth midwives do that on a regular basis. I am one of those that I guess that was being spoken about when it was said over and over again that certified nurse midwives would be equalizing themselves with those with no formal education and with no standard board. I have no college. However, I consider myself very well read and very well studied in obstetrics. Personally, I have a real problem with that equalizing themselves, saying that maybe somebody else is better than I because they have been to a certain type of school. As a homeschooler for over 20 years, we've had to fight battles over and over again to say that, yes, we can do things as well as a certified teacher, even though we haven't necessarily been to school. And I think the proof is in the pudding. The homeschool students are coming out just fine without the parents having to have a certification behind them. Hold on a second. I took lots of notes. I'm sorry. One statement was said that all the education needs to happen in a didactic setting. However, and then the statement was made that apprenticeship knowledge is worth more than a formal education. Well, you can't have it both ways. A didactic setting is different from an apprenticeship knowledge education setting. I do believe that there is room for both of those. I'm sorry. One statement was made that half of 1% seems low, but not if it happens to you. However, the iatrogenic problems that are caused in the hospital are higher than half of 1%. And these women aren't given a choice topped out. We were told that informed consent needs to happen, and we all want that. But the informed consent that happens in a hospital setting sometimes seems to me that it's less than what happens in a home birth setting, where the midwife goes over and over and over with the patient. This is what could happen. These are what your options are. I have seen the informed consent at Phoebe Putney Hospital. It's 2 sentences long. And it says, my doctor has explained everything to me about what could happen, and I agree that he can treat me. That's not informed consent. It doesn't talk about the risks or benefits of IV. It doesn't talk about the risks and benefits of each and every drug that might be given. That's not informed consent. One of the statements that was said was that you can't very well match home birth with hospital birth patients, but yet it has been done because, you know what, a lot of people they aren't forced to go to the hospital. Some people choose to go to the hospital. People who are in states where they are allowed to have home birth and it's legal, they choose to not have a home birth. So then you can study those, and I have a copy of a study done where they do matched stats here. It was mentioned over and over again about Brazil, and Brazil has this wonderful C-section rate. In 2005, Brazil's infant mortality rate was 29.61, and I'll leave that with the committee. For the questions about C-section rate, I have some questions that when you ask the Georgia Department that I think would be really helpful to find out. All right?
Next speaker. Thank you very much. Please sign your name, address, phone number, anything that would allow us to be able to get in communication with you after the fact.
Thank you, Lord.
My name is Carolyn Drake, and I'm a certified professional midwife. And I also hold a Master of Arts degree in history, specifically childbirth history and midwifery history. There's been a lot of talk on the safety of childbirth these days here, and some of the emphasis has been put on how things used to be and that it used to be unsafe for women to give birth at home. And it is more accurate to say that women did not have the kind of conditions that we have today in the United States or elsewhere in this world. Women had a thoroughly different understanding of health care in the first place concerning the 4 humors. We can all spend a day talking about that, but we won't. But their outlook on health was completely different back then. They did not have running water. They did not have clean sanitary conditions. They hardly had enough food to put in their bodies throughout the day. My history research goes back to the 1600s, the 1700s, the 1800s. I have picked up and read midwifery books written by men during that time and some by women, and the conditions under which women lived were astronomically horrendous. No wonder that women died in childbirth. A lot of people died of a lot of things during those days because we didn't have the kind of conditions that we have today. It's like comparing apples to oranges. You cannot compare today's modern conditions with the past. It cannot be done. It is not fair. It is just like saying that obstetricians can be condemned and blamed for all those women who died during childbirth because they didn't wash their hands. They did not have an understanding of germs. We cannot go back that way and say birth used to be dangerous. We have to be more accurate in our description of what childbirth was then and what it can be today. And today, as this woman said just a minute ago, women have the option of having a midwife come to their birth or come to them for their prenatal care with complete information on nutrition, about their care of their bodies during their pregnancy. They have information given to them on the aspects of their pregnancy. They know that their heart beats, the blood goes through their circulation, through their body, and it doesn't just like, we have a completely different understanding of childbirth and pregnancy today that midwives today educate themselves about. We have missed the fact that midwives here in this room today, they just don't, say, they pick their books up and they read them, don't you? Right? And you guys, you probably know a lot about childbirth history too. And it's great that you have these people in place for our state in Georgia. We need these women who are willing to spend most of their lives and devote most of their lives to studying childbirth, picking up those books, going to online study groups, to joining schools, to going to schools, to getting together in study groups, to offering women their knowledge, and women are lucky and midwives are lucky that this legislation today is trying to help this process in a way that will enable women in the state of Georgia get safe choices from midwives.
Thank you.
Sign up, sign your name. Sign your name if you spoke so I can know who's speaking. And David, Ms. Sapp, did you put your name on it? Okay, thank you. Yeah.
Hi, my name is Mercy Barker. I am a consumer of home birth. I have a Bachelor of Arts degree in Industrial Engineering, and I was also formerly an air traffic controller before I had children. I say all that just to show you that the mothers that are having home births are not, we are a wide spectrum of women. Women of high school educations all the way to perhaps college educated, perhaps even doctors also. The biggest thing I want to stress is that Georgia law gives us the right to have our babies at home. And all I'm asking the legislature and your study group to do is to come forth and make it possible so that when we have our babies at home, we can have legally a midwife there to help us along, to direct us. I think most women who give birth at home are not just dropping their babies on the ground as they're birthing them. We're educated in birthing practices and nutritional things, and so I ask that the legislature would be very careful in what they come up with, so that it would be a help to the women and not keep us bound up in fear of, well, is someone going to be turning in my midwife because I'm choosing to have her here at my birth.
Thank you very much. Do sign your name, sign your name, sign your name.
Hello, my name is Agape, and I really just wanted to speak to the spiritual experience that having a baby is. Everything walking the planet either has a womb or came from one. So before there was government or HMOs or whatever, if I was in the woods and had a tree and just squatted down, my body would have the baby. It's not really an issue of education as much as it is the whole process is taking place without your eyes. This is something that God's doing. So you're just meddling with everything that's going on. It's meddling, and we have to protect the right to be able to make the decision, because this is not an episode of ER. I'm having a baby. My body's having a baby. It's been being done since people came on the earth. It's the only way you could get here. So I don't feel like we even need all this paperwork. But because we do, that's the reason why I came out today, is because this lady right here has delivered 2 of my babies. This one right here. She's fine. I never went to a hospital, haven't been to one. And when I did go for my little checkups, it was just to use an ultrasound machine, because that's all y'all doing for me in the medical field, is letting me see something that I couldn't see before, that I had to trust on and have faith for, which is what I do and will continue to do. So I just wanted to make sure that the spiritual experience was spoken for, because the one process of a woman having a baby is about liberation too. So all these cesareans that you're talking about, let's follow them women up and find out how their postpartum is too. Find out how they're feeling after, because their body didn't release the hormones, they didn't go through the process, and then what? Because it's being taken. Whereas the people who built the hospital, who birthed them? Probably their grandmama. So it's not really about that. And I just wanted to make sure I speak to the spirit of the situation, because this really is semantics. You know, a woman's body does what it does, period. It happens when it happens. It's a process that was ordained by something higher than everybody who can sign a dotted line. So I just wanted to make sure to give up to the liberation for everybody in the room who wants to do that the right way, the way it was divinely processed to do.
Whoa. Okay, come on up. We got about I'm so easy. I'm going to give you another 5 minutes.
My name is Rajani, and this is my son, Abraka. I feel from my experience, my first child, and my home birth was so blessed. And I am also a doula, and I've been at several births at home and in the hospital, which have all been good. But I know I could never have had the experience that I had at home in a hospital. And I also learned from my experience of birthing how personal, how deeply personal having a baby is for the whole family. When you are in birth, it's you and the Creator and your child. There's nothing else is going to carry you through. And choice for that woman and that father, that mother and father, choice is paramount, because to be empowered is very much what birth is about. You have to feel and know that you're empowered, not just to bring the child into the world, but to raise a human being to be a morally strong and viable contribution to the world. And to be able to do that, you have to feel that you're empowered. Making a choice gives you that from the beginning. And I heard everyone speak about women who choose to have C-sections and to be induced. And I know women who choose to have C-sections, and that's their choice. They're my friends, and that's their choice. Legalizing home birth does not take that choice from anyone. But making it illegal for a home midwife who is highly educated and very capable to not just birth the child, but educate. You know, my midwife educated me. I learned how to check my own dilation of my cervix. I learned about my body. I became a stronger woman. I became a woman, I feel. And it wouldn't have been the same experience had I not had that whole education that comes with most women who choose a home birth are women who choose a lifestyle. It's a holistic way of living that goes along with that. It's not a random choice. We know there's risks. You know, we are aware of risks. It's very serious. It's not just painful. It can be life or death. And I've seen that time and time again, and still chose to have my baby at home. And I feel like there has to be some respect for the empowerment of a woman to make a choice for her body, for her family, for her baby, in the most sacred and life-changing aspect of her life, which is giving birth and bringing life onto the planet. So I support that, the power of choice and the empowerment of women and families to have healthy, educated beginnings to their families.
All right. Next speaker. What I would like to also say to people, I want to remind the audience that they can also submit written comments to the committee. So even if you don't speak today, if you have something written, we'd like to have that, because we'll use all those documents when we begin to sort of look at which way to move forward. So please sign your name, and we'll get back in touch with you. But remember, you can get written comments that we will accept. How many more people are thinking about speaking? 1, 2, 3, 4, 5. All right, I'll let those 5, and we're going to have to close it, only because we can also have it open again for you on the 28th. Okay, thank you.
Hi. My name is Alexa, and I came from a family, a very medical family. My mother was a labor and delivery nurse for 30 years, and my stepfather, an OB. There, you can draw right here. So I grew up, you know, this was before pagers and cell phones, or pagers were just starting off, so people called the house and we always knew exactly what was going on. Anyhow, I graduated from college. I have a bachelor's degree as well, and graduated with high honors. And, of course, my family wanted me to go to medical school, but I wanted to become a midwife. So I am an apprentice midwife, and I started my studies in 2000. What I wanted to speak about was just the sacrifice that midwives go through to do what they do. You play with your train. First of all, it's not legal in Georgia, and so we have no education programs in Georgia. There are no formal education programs for direct entry midwives in Georgia, whereas there are in several states. For example, Florida has I think 4 different direct entry midwifery schools. There are several states around us that do. So, besides the sacrifice of, okay, basically, there's a huge financial sacrifice that midwives make, then that midwives' families make. There is the tuition that we pay for courses, for conferences, for certifications, for neonatal resuscitation and CPR, for all of our textbooks, which cost just as much as any other medical textbook or college textbook. There's the gas money. There are no midwives in my community. I travel an hour and a half to apprentice with the midwife I apprentice with, and I've traveled up to 4 hours to attend a birth with her. There are child care costs because someone has to take care of my family while I'm away. And there's the equipment that midwives have to buy and that students have to buy. And lastly, there's the lost wages because I can't have much of a job while I'm on call for women and families attending birth. And besides the financial sacrifice, there's also just the personal sacrifices of knowing that you may be at a birth on Thanksgiving, or you may be at a birth on your child's birthday, or you may get called in the middle of the night when you had other things on your mind. You may get called on your anniversary. You don't know when you're going to get called. As midwives, especially midwives in Georgia, we don't have vacations. We don't have benefits. We don't have a lot of the things that people get that have normal, recognized jobs. Midwives in Canada actually do get those things. Midwives in Canada make salaries of about $50,000, $60,000 a year. That's a starting salary for a midwife attending home births in Canada. And you get health insurance, and that's another thing that we don't get. So, I just wanted to say that the sacrifice, I've been working on this for 6 years. So, obviously I had a child, but because of the financial burden that my husband has had to kind of make up for and everything else, it's taken a really long time. And because of the lack of an educational program in Georgia. So I hope that when midwifery becomes legalized in Georgia, that we can start to look at a formal education program that includes all the routes to midwifery, that includes apprenticeship, that includes didactic learning, that includes hands-on skills, workshops, and all of that. And the personal and the family sacrifice to become a midwife is profound, but we keep doing it not just because we want to be midwives, but because Georgia women want midwives. And they want to have home births, and will continue to do it. And also, there was a lot of questions about the labels, all the different midwives' names. There are many different words for midwife. There is a standard that Susan Hodges and consumers all over the country have worked very hard on, and that's the CPM standard. And granted, there are issues when you create a standard and when you want all midwives to stick to it, and we've seen that in different states. I'm almost done. Midwives have had to compromise in states where it's become legal. Florida has definitely had to compromise since they've had legalization. But women in Florida have access to home birth because Medicaid covers home birth in Florida. So I just want to say that I hope that midwives and everybody can join together and unify and really keep the goal in our forefront. And the goal is providing midwifery care to any mother that wants midwifery care. And I think that doing that, we're going to have to follow the standard, like people were saying. And CPM is an excellent standard. The NARM test is an excellent way to go. So I hope that the state can also provide assistance to women wanting to go those routes. Thanks.
Okay. Thank you very much. Please sign. Maybe the next speaker. I told y'all 2 minutes, but y'all ain't doing it. Y'all are going to take me to 2 o'clock, and I'm gonna be, but that's okay, I'll be the only one listening in, because my committee members have told me that they have appointments. So y'all going to have to give me a little break, because I'm giving, usually we go on by now. These committee members have other obligations as well, y'all.
Hello, everybody. I'm Terry Bowles. I am a lay midwife. I'm also a mother and a doula. And I want to give honor and thanks, first of all, to our two granny midwives that are here, Saran and Nasra. Without them, I would not be here. They are the reason that the calling is so strong here. And also to Debbie, too. I know Debbie. She's a really good friend of mine as well. And I want to speak on about VBAC, first of all. I'm a VBAC mother. I had my first child. I was 18 years old. He was 8.5 pounds and 1 ounce. I went to the hospital. I dilated fully 10 centimeters. Then all of a sudden he started decelling. Okay. The next thing I knew, physicians were running into the room, screaming, saying, your baby is going to die. Your baby is going to die. Sign on the line so that you can get a C-section. My mother was so scared that she cried to me and said, please sign so that our baby won't die. Okay. I was so mad because I didn't have a choice. They made my choice for me. Now that I know what they could have done, I am mad as hell. Because women do not have enough information to understand what's going on with their body. If they simply had not had me laying on my back with my legs up in stirrups, if I would have had a choice to move around, to be able to get into another position, I would have had my baby. And there would have never been a C-section. After that, I said, no more C-section for me. And I had 3 babies below after that. Fine, all healthy babies. No medication. It can be done. In my case, I know in some other women's cases it cannot be done. But in my case, it was done. And for me to sit here and to hear that women don't have a choice and that their decisions are made for them is not right. It is not right. We as midwives inform our clients of all the different choices that they have to make. If they want to see us for prenatal care and they want to continue to see a provider, okay, that's fine. That's her choice. She has choices to be made from, and not someone making their choice for them. And breastfeeding, I came from a very medical family too. I didn't have anybody to teach me how to breastfeed or to come in and let me know about breastfeeding. But when I got a midwife, she told me and she taught me and had me to, do my own research on breastfeeding. I breastfed 2 babies at one time. Not twins, but 11 months apart. And it can be done if you have the right information, if you have someone that is giving you the right information. We midwives are not just going out there and saying we want to be midwives and then we're not looking at books. I went to a traditional midwifery school in Asheville, North Carolina. Taught me the sacredness of birth. Taught me what authentic birth and genuine birth is. That is what I pass on to my clients. I give them the alternative choices. And we don't have any other educational programs here in Georgia for that. Most of us have to go away to get the education that we need if we're not apprenticing with midwives. I apprentice with a certified nurse midwife as well as with a lay midwife. I apprenticed with both of them. And what I did was took that empowerment from both sources to empower myself so that I can be able to give my clients the quality care that they need.
Thank you very much. Don't forget to sign.
Okay, baby.
My name is Deborah Miller. I am a registered nurse and also a lactation consultant and also a home birth midwife quite a few years ago. I don't think, from all the speakers that I've heard today, I have not heard anybody say anything really different. Everybody wants healthy mothers and healthy babies, and everybody talks about choices. And choice is important. It's very important. I had that choice. I was in another state with my first child. Unfortunately, the choices are extremely limited. If you want a natural birth in a hospital, it is very difficult to achieve. You may find a certified nurse midwife who believes, but she's got 3 backup doctors who disagree, and she is under their authority. So if something comes up during labor, things change. So I think it's really important that women truly do have a choice. And I will be the first one to say, not everyone will want a home birth. I don't think anybody has to worry about that. I think we're a small minority of women who choose to take that responsibility and want that availability to themselves. But I think it's important that it is available in a safe way. Unfortunately, in the community that I live in, home birth is not a safe choice. There is not good medical backup. There are no physicians who will see you during your pregnancy and be there at the hospital for you. So women who are choosing home births in my community really don't have a safe option. I have several women that I know of that are leaving my community to come to Atlanta because they can find at least a physician or a nurse midwife who is closer to what their choice would be. So I think it's important that we really look at the options that women truly have, whether it be VBAC or whatever, and make those options available safely for everybody. Thank you.
I think one of the committee members want to know what area are you from in Georgia?
Columbus.
Okay. All right. Next speaker.
My name is Juliana Northup. I'll be quick. I just wanted to let you know, I went to Birthwise Midwifery School in Bridgeton, Maine, and I left there and moved to Georgia to be with my husband and had 2 babies. My first baby was born in New York 16 days after my mother passed away, so due to a lot of things that were not under my control, after 30 hours of labor, 3 hours of pushing, and a doctor who wanted to stop my pain and gave me pain medication. I was then so loopy I was unable to push my baby out and ended up with a C-section, complications that had me in the hospital for 5 days, and complications that lasted way more than 6 months. I also am a breastfeeding peer counselor at the WIC office in Rockdale County, and I am tandem nursing 2 children. And I would like to say that this is little Miss Tessa, and I did have her in the hospital. I was unable to find anyone to let me VBAC in Conyers, but I did VBAC in the hospital. I stayed home as long as I could possibly stay home, arrived at the hospital 10 centimeters dilated, and just pushed the baby out because that's what I had to do. And they were not going to make me have a C-section when there was a head crown, and I was guaranteed that. Luckily, she was my miracle baby and came in 3 hours, and I did not stay home on purpose. She just decided she was going to come that way, and so that's how we came. By the time my husband got home from Atlanta, all the way to Conyers, and then we made it to the hospital after getting him child care. I arrived at 10 centimeters, not because I stayed home. Everybody says to me, "You stayed home. You wanted a home birth." I was like, no, she wanted to be born this way, so she came fast enough to be born this way. And so I'm here to say that women need choices. I was played the dead baby card more than once during her birth and pregnancy, and everybody kept telling me, you can't do this. The VBAC rate is not good. You're going to have a ruptured uterus. And and then I went late. She was 8 days late, so then they wanted to induce me, and I kept saying, no, you're not inducing me. You can't induce me. I'm a VBAC. That's the worst rate, and they're like, well, then you're going to have a C-section. No, 2 weeks is, let me go to 2 weeks, and luckily I didn't have to fight that very much, but to just fight, and I was with an OB in the hospital where they say I had to be. I wasn't even fighting for a home birth. Women have to fight for the rights. I should not have had to fight to have a baby VBAC with an obstetrician.
Your son would like to speak. Would you like to speak? He wants the mic. Okay, all right. next speaker.
I just wonder how many people walking the halls here has any clue with all these mothers and babies. But that's just not done at the Capitol.
That's right.
Hi, my name is Rebecca Sapp. I am not a professional. I have not had any babies. However, I want to speak to you about the rights of women. It's been said this Georgia legislature recognizes a woman's right whether or not to decide whether or not her baby will live. I find it ironic that they do not recognize the woman's right to decide if her baby will be healthy, where that baby will be born, and in what kind of environment that baby will be born. Because direct entry midwives are not allowed to participate in home births, women are denied the right to make those decisions for themselves. Police organizations recognize a woman's intuition. Sometimes you'll be walking down the street, you just know somebody's behind you. Same thing has happened. I've heard women tell me they have a feeling about their birth. They just need to have this birth at home. Because the right to have a midwife at their birth is denied them, they have to face an unattended birth at home if they want to recognize that intuition and follow through with it. That's all I have to say. Thank you very much for listening to me.
Thank you. Young man, would you like to speak? Okay, you would like to speak? You want to speak? Come on, go ahead. You can speak.
Or sing us a song.
What do you want to say?
Are you going to say something? Come on.
He's a showman, though. We see that, though. We see he's a showman. All right. Is there any other speaker? Okay, yes. That'll be our last speaker that's coming up. Y'all are doing wonderful. So y'all got to come back on the 28th for us to final meeting. All right.
Hello. My name is Tolewa, and I am a direct entry midwife. I trained through an apprenticeship and a direct entry program. Is that better?
Yes.
Okay. My name is Tolewa. I'm a direct entry midwife, trained through an apprenticeship and a direct entry program in North Carolina, which I love, the Matrona. And my experience personally, I have 2 home birth babies and 1 hospital birth baby. My hospital birth baby was my eldest daughter. She's 6. And she helped with the other 2 deliveries. And it would be nice if she was up here to tell you her experience too, but I know you guys don't have time for that.
Is she here?
Yes.
I'd like to hear a little bit of it.
But what I wanted to stress, through the speakers and all the speakers that came up, well, some of the speakers that came up, kind of emphasized that midwives are not educated, that we don't know medical terminology, that we don't have formal training, and I feel like that's a misnomer. None of us in here who are practicing midwifery are idiots. All of us are well-read, well-educated. In fact, many of us are more in line with what's current than a lot of the doctors that are practicing. Because, as we know, information is constantly coming, and we're always improving. I feel midwifery is always improving on the old traditions. And the old traditions are tried and true. And we also have new information that helps us to understand, like, for example, immediate cord clamping. I know many doctors still do that, even though it's a recommendation that was withdrawn by ACOG. Even though, and majority of doctors, because I do doula work, and I present this information to my clients when they decide that they want to delay cord clamping, these doctors have no clue what I'm talking about. So that just tells me that there's a disconnect with the education. You know, it's not always Emory or another formal education that's the end, and you have all the information that you need as an obstetrician, and that's it. It's continual, just like with midwifery. It's continual. We continue to increase our knowledge of birth by birth experience, the best way to learn. Like electricians, like plumbers, they all learn in apprenticeships, and we allow them to come to our house and wire our houses up, which could kill us if it burned down. But they learn through apprenticeship, so we have to value that experience, that hands-on experience that comes, and that's greater than, I believe, a book with somebody's theory about how things happen. I try to, when I get in situations where I have to talk to doctors, my first question to them is, have you experienced a birth that has not been managed? Have you experienced a birth that does not have, for example, continuous fetal monitoring, where the mother is told what position to be in, where the mother is told that she has to have an IV, where the mother is told she needs to be on oxygen, where the mother is told she has to progress on this curve in order for her to be considered to have a normal delivery. People consider normal delivery a non-medicated delivery, but that's not true. Normal delivery is deliveries where women are in charge, are the co-chairs of their care, where women are empowered through their providers to be active participants. That's normal delivery, not a non-medicated delivery. And if some of the doctors that spoke could speak on their experience with normal deliveries, then I think that we would have a more equal, playing field. Because I think very few doctors in this country have ever experienced true normal delivery. Okay, maybe not.
Okay, let me ask you this. Were you there when your baby brother? Baby sister? You were?
Yes.
What did you think about it? Did you like it, or did you get to help?
Yes.
We both heard the. Okay. All right. Well, we're not gonna put no more questions on you at this point. But we thank you for being here and participating. Okay, young people. Let's give a hand for all the young people. So this concludes the fourth hearing of the study committee. We will be back here Thursday, December 28th, same time, same place. We appreciate it. I also just want to recognize Ms. Claire Westall. We appreciate you staying all the way through this as well. And please have a safe holiday, and we just wish you a lot of love, a lot of joy this holiday season. Thank you very much. I am Abel Mabel Thomas, State Representative. Thank you very much.